physician or APP who treats prostate cancer here in Louisiana, we'd like you to consider attending. It's going to be in the Track 4 room, closed-door session about prostate cancer. And we're going to be brainstorming, we're going to be looking at this data, and we're going to be brainstorming some ways to improve practice patterns for prostate cancer in Louisiana. All right, I appreciate it, and I will hand it over to our block chairs. Thank you, guys.
Absolutely love this concept, and they sometimes want it before it's even ready to go. So when we go through, thinking about, we've always had, radiation and surgery and hormonal therapy and chemotherapy. This chemotherapy since the mitoxantrone days, 1993, 94. So we've had those kind of building blocks for a long time. What's changed is actually a lot. Genetics are now part of our routine care, both the somatic genetics as well as germline genetics, recommended by NCCN for virtually everybody with advanced disease today. Molecular imaging, things like PSMA PET, has totally revolutionized the way we look at the disease. Artificial intelligence is coming. There's something called Altera AI that looks at pathology and makes projections over the future of the patient to predict hormonal sensitivity and more. Targeted therapies, things like the PARP inhibitors as well as the PD-1 inhibitors are now approved in certain selected settings. Immunotherapy in the selected settings. One of the immunotherapy that's exciting right now, and really talk about it, what we call the T-cell engagers, things like pasritamig, which are binding KLK2, like our number of targets, and opposing that with a CD3 and activating the immune system selectively and KLK2 microenvironment. Very interesting. And then molecular target radiation, which I'm going to focus on. So, lots to talk about. For diagnostics, it's such a simple principle. You want to be able to see it, and then you treat it. And I say I love it because it really sort of changes the paradigm for how we approach the disease. The key elements are, on the cancer cell, you need a target. And that target should be expressed on the cell surface, ideally. And it should be selective in a reasonable way so that the binding to this cancer cell has specificity over and above that of the normal tissue. Now, when it gets a little complicated is when you look at the short-term scans, like the Gallium-68, you're looking at a 1-hour intention. And you can get deceptive findings because the washout that occurs in some of the normal tissue is not seen unless you do what we call dosimetry, long-term imaging. You need a ligand to bind that cell surface. You need a linker it is going to be able to detach the radionuclide into the ligand. And by the way, you don't always need that, because sometimes you can use like F18 and attach it with a halogen directly to the molecule itself. And then, depending whether or not you're going to have a PET imaging agent like PSMA, gallium-68, or F18 used for diagnosis, for therapy, you need a therapeutic isotope, and that's something like lutetium or actinium. So, the concept is you want to see it, you want to treat it. For molecularly targeted isotopic therapy, which is one of the terms that I use, there's a whole diversity of potential targeting molecules. There's small molecules like this PSMA-617. There are bicycles that are being looked at for Nectin-4. There are a whole variety of peptides, some of which are in use in prostate and beyond. Various antibodies and antibodies. Aptamers is now an aptamer company that's pushing forward. And also diversity of isotopes. So a lot of different ways to combine these stuff, and a lot of different ways to bring the isotopes, all of which are different and depending on what sort of kinetics you're looking at. One of the reasons I really do enjoy working in this area is we're dealing with cellular heterogeneity to some degree in advanced cancer. It's just part of the problems we face. Not all the cancer cells are the same. Not all of them express the same target. And when you're using this radioligand approach, you're actually creating something called crossfire, because the beta particles are going to be going on for about 1 millimeter or so, so pretty controllable radiation, but you don't have to have the target expressed on every single cell. You can actually bind to one cell and kill another that's adjacent. Plus you alter the microenvironment. And the microenvironment includes things like the vasculature, the supporting stromal structure, which is important for the cancer cell growth. And this ability to generate crossfire helps to overcome the heterogeneity, and I think really contributes to the success we have with these approaches. The smaller tumors, however, once the tumors get small, you don't generate enough energy in the cells you bind to, so single cells are not well targeted in this approach. Maybe with an alpha, maybe with an Auger, it's a little bit of discussion. But for the betas, which are things like lutetium, kind of our workhorse, you need a group of cells together in order to generate the crossfire to bring the cell kill. This is an important paper because it's pivotal for the FDA approval of Victo and New England Journal a couple of years ago. Just going through some of the data, which you may not be familiar with. These are patients who really were very, very end of life. They had already had at least one taxane, maybe two, about 40% of the patients had had 2 taxanes. They had to have at least one FDI, the abiraterone enzalutamide typically, and often 2 or sometimes even 3. And they basically had exhausted their therapeutic options. So coming into this really late stage patient, the patient's randomized between just the standard care, the docs could do whatever they want except for chemo, and plus or minus lutetium. And they had 2 primary endpoints, both PFS, progression-free survival, and overall survival. The patients were selected with a PSMA PET scan because you want to make sure the target's there, and 87% of the time the target was there. So we ended up actually scanning in this particular trial slightly over 1,000 patients, about 1,003 patients, and 87% met the PSMA PET criteria, which was PSMA PET positive by the liver in a metastatic lesion. There were exclusions for those who had a PSMA PET negative finding that was seen on conventional imaging. The most common one is the liver. The liver develops metastases, and they're not always PSMA PET positive. And the liver lesions are a common reason for exclusion. If you're treating somebody with Pluvicto, PSMA-617 lutetium, and have liver lesions and they're PSMA PET negative, you probably ought to be doing something else. Anyway, we brought this forth. Here's the overall survival on the left and RPFS on the right. Both these were substantially positive. Hazard ratios of 0.62 and 0.41. And there were some unequivocal findings. The FDA basically liked what we saw, particularly with the overall survival, and that led to the approval. There are a couple of things that were interesting about it. These are subset analyses that I'll share going forward. One is that the PSA decline at any time before the 12-week point. So the second, this is given every 6 weeks. So your first dose, and then your second dose at 6 weeks, and then we give actually your third dose at 12. So before is given, if you look at the PSAs, you can really stratify the outcomes very quickly by looking for PSA declines. Those people without a PSA decline are not going to do well. Those people with PSA decline are going to do very, very well. So it's just a simple biomarker going in, and I typically measure the PSA 10, 11 weeks, and I kind of know what's going to happen at that point. The other thing that's interesting is to be able to look at the degree of uptake on the PSA PET scan. So there's something called whole body SUV mean, which basically looks at the PET uptake and quantifies the degree of uptake that you see on the PET in the metastatic lesions. And the more uptake you see, the better the patient is going to do, because you have better binding. So better binding translates into essentially more effective therapy. So this is an image-based biomarker, in addition to the other biomarkers we use, like circulating tumor DNA, etc. So image-based biomarker is actually important, and I pay a lot of attention to the degree of uptake that we see in the scans. This is another way of looking at the degree of uptake. There are two elements here on the top. We see the RPFS, and the bottom we see the OS. The print's a little bit small, but we're looking at the SUV mean cutoff, and we're going all the way on the OS from 7 up to 28 is over there. And the hazard ratio that is shown, the lower hazard ratio, means that there's a better outcome. And you can see this sort of linear relationship between overall survival and the SUV mean that is done as a baseline PET, so that's good. On the right-hand side, the right-hand column, you see kind of the multiple colors. And I'm colorblind, so I always get confused. I think that's the other one. Hopefully there's one that's getting initially kind of large, and it gets smaller and smaller. Those are the number of events that occur over time. And the number of events that occur over time diminish as the SUV goes up, meaning patients die less, basically. So that's important. This is a wonderful Mayo Clinic that we put together, the Mayo Clinic series, where we just looked at those people with liver metastasis. And these are patients who got treated, liver metastasis before, by the way, with almost any therapy, including the PSMA petition. So liver mets are bad. Always try to get rid of them if I can. That's just one of the important things. So we finished up the VISION trial. We learned a lot. We got an FDA approval, but there are a lot of things we did not know. I think it's important when we talk about trials, not only about what we do know, but what we do not know. And here we see about optimal patient selection criteria, then a question mark. You know, we drew a threshold that uptake in greater than the liver, but the truth is, I've now shown you that the SUV mean as it goes higher, the patients do better. And that's something that we can put into the selection criteria. Optimal dose and schedule was not explored. We used a dose of 200 millicuries or 7.4 gigabicrels Q6 weeks times 6. It hasn't been adequate dose and schedule exploration. We're doing that now with other agents. And I'll simply say that there are better doses and better schedules. What are the mechanisms of resistance? We're still struggling with that. How do we best monitor and detect response and resistance? Well, we know about PSA, of course. But really, we don't have all the data on the scans yet. We need repetitive scans in order to be able to show. And I'll tell you, the total tumor volume is a manuscript in press right now that I'm a part of, looking at total tumor volume on the PET scans. That is really, really important. So if you start with 500 cc's and you drop down to 100, that's really important. If your volume goes up, that's really bad. Simple parameters. Takes a little bit of AI to do it properly because you're trying to integrate all those number of lesions. You may see 49 lesions, and you ask, what is the total tumor volume for the metastases? So you need to integrate that. It's not super easy to do it without some AI, but with the AI, it's quite easy. How do we add particular treatments or combinations? That's a big, big issue. I'll come back to that. Pre-chemotherapy space, castrate-resistant space. All these issues are yet to be determined, but we do have now an FDA approval in the earlier stage. This is not an FDA approvable trial. This is out of Australia called INSAP. It's interesting to me because the best hazard ratio ever shown in the history of castrate-resistant prostate cancer is this trial. Hazard ratio is 0.549 or 0.55, I think they rounded it off to. And it's a pretty simple trial. It's just castrate-resistant. And everybody knows that enzalutamide is a very effective therapy for those with castrate-resistant disease. And here you have enzalutamide as a control arm, and you have enzalutamide plus lutetium in the experimental arm. And the hazard ratio came out strongly positive. I can't see the numbers, but I know it. There it is, yeah, 0.549. You can see, and this is really strongly positive, suggesting that maybe synergizing with the hormonal therapy could be important, at least in this setting. But remember, these are patients, which I didn't explain, that had not been pretreated with an ARPI, no abiraterone pretreatment, no enzalutamide pretreatment. This is just ADT. So it's a little bit antiquated today, where almost everybody gets an ARPI up front, right? Darolutamide, apalutamide, enzalutamide, abiraterone, all FDA approved in the upfront setting. So I have a bunch of important phase 3s. The PSMA-4 is now FDA approved. SPLASH was presented at ESMO 2024. ECLIPSE is announced as positive, but we haven't seen the overall survival data. I think we might see it later this year, maybe ESMO, we're going to see. I'm going to go over the PSMA-4 because we do have an FDA approval. That's from the Lancet paper that summarized that phase 3 trial. This is in what we might call the taxane-naive space. So these are people who had an ADT and an ARPI, and then were being randomized to a second ARPI versus lutetium. The FDA would not allow us to use combination therapy, which is very irritating, but anyway, we do have the FDA approvals starting about a year ago, March 28th of 2025. Very similar design, confirmed progressive metastatic CRPC, castrate naive, being able to have PSMA PET positive lesions, and had to be greater than liver to be defined as positive. And patients were randomized to the second ARPI versus the lutetium. In this case, it was a crossover design, so if you crossed over the control arm, you'd have the ability to be treated with lutetium as part of the trial. Patients were predominantly treated with abiraterone, with enzalutamide kind of being a close second. And I'll simply say that there's a lot of patients here that are similar to what we use today. And some of these patients were treated with ARPI in the castrate-sensitive setting, some in castrate-resistant. But the bottom line is that they did much better when they got the lutetium. Here you can see the hazard ratio 0.43, which is obviously good. And it turns out that this led to the FDA approval. Here's the time to the PSA progression. Again, you see the positive outcome with lutetium. Hazard ratio here is in the 0.4 range. So this is clearly a positive trial, published in Lancet, now FDA approved. The survival was 0.91 for the hazard ratio with confidence intervals that overlapped 1. But please remember the crossover. 57% of the patients in the control arm crossed over to receive the lutetium, was 82.2% of those eligible. There was a crossover adjusted analysis, one called IPCW, and I'm not a great statistician, but the crossover adjusted analysis came out positive for OS. Anyway, I'll simply say we have OS in the advanced setting. I think we'll probably have OS here if we design the trial without crossover, but that's not the way it happened. But it did lead to the FDA approval. What about castrate-sensitive metastatic disease? I mean, that's sort of the next step. And now we have the PSMA addition fully accrued in 2024, reported at ESMO 2025 by Scott Tagawa as first author. I'm the co-first author on that manuscript. Actually, we just submitted the manuscript revision to Lancet, so we anticipate another Lancet article from this particular study. There's the RPFS. Preliminary, relatively immature data, but nevertheless hazard ratio of 0.72, confidence intervals not overlapping 1. I think that this will have a good chance of getting through the FDA. We have to see. The overall survival is still quite immature, but it was 0.84 for the OS, and that's kind of to be expected that there would be a positive trend, but we need more. Now, can we go even earlier? So I've kind of covered FDA approvals, castrate-resistant and kind of taxane-exposed, castrate-resistant for those who are taxane-naive, hormone-sensitive. Now we're going to drop back even further and talk about those who are PSMA PET positive and conventional imaging negative. So these patients don't even have a positive bone scan or CAT scan, they're just PSMA PET positive oligometastatic disease. And there's a trial called the PSMA DC trial, which we put together, asking the question, can we avoid the use of androgen deprivation in this setting? Now, there's a small trial put out by the group at UCLA called the LUNAR trial. And they basically did a similar study, but without putting together the endpoints that are FDA approvable, which is a little bit of a problem because you can't take this to the, well, they took it to the regulators and the regulators say, slap down, come back later. But on the other hand, the PSMA DC trial is designed with regulatory approval endpoints. Here you see a PSMA PFS here. This is PSMA PET scan, which is a non-regulatory approved endpoint. Hazard ratio was 0.37, showing that the addition of lutetium to SBRT to the oligometastatic lesions provides benefit in terms of time to progression. No androgen deprivation being used here. This is the PSMA DC trial. It's accruing quite nicely. It's almost halfway done. And it's an international trial looking at the oligometastatic PSMA PET positive space, avoiding the castration. Everybody gets SBRT to the oligometastatic lesions. Half of the patients, actually 2/3 of the patients, are going to be randomized. It says 1-to-1, but that's actually changed to 2-to-1. So 2-to-1 randomization with an MFS endpoint, metastasis-free survival here with conventional imaging, which the FDA has said, if you hit that endpoint, we'll give you the approval. So that's ongoing right now. One of the things that's a little bit interesting is most of what I presented is with lutetium, but it doesn't have to be lutetium. There are other isotopes that we can bring to the fore. One that's very interesting is called terbium-161, and there are significant trials going forth with terbium-161. And the terbium seems to be better on the single cell kill or the very small cell cluster kill, which is one of the shortcomings of lutetium. When you get smaller and smaller on the cellular scale, you have less and less effect. But that's with lutetium. When you change the isotope to terbium, you can do better. And also, if you change it to the alpha particles, you can do better yet again. What about synergistic opportunities? I think this is really important. You know, so far what I've shown you is monotherapy. We just use lutetium without much else. We did in the VISION trial while standard of care, but it was like whatever. You know, you put in steroids or third-line ARPI or the choices of palliative radiation, you know, whatever. But here we're beginning to look at things in more detail, particularly with DNA damage repair pathways. We believe, and most of the data is consistent, when you're using lutetium in the isotopes, it's really working by damaging the DNA in those cancer cells. And if you inhibit the repair of the DNA damage, it makes sense that you would be able to provide some degree of synergy. And the preliminary animal model data says that. There are PARP inhibitors, ATR inhibitors, ATM inhibitors, DNA, PK inhibitors, and more. All of these are being looked at in various experimental forums. But we have clinical data with the PARP inhibitors. It's a trial called the LuPARP trial, done in Australia with Janine Sandhu, who's a really excellent investigator down there. The PSA90 responses are really good, 44%. It's a dose escalation trial, which she started very cautiously with the olaparib, which is an FDA-approved PARP inhibitor in prostate cancer. But these are patients without DNA repair defects. These are just all comers. And the bottom line is, she reported at ESMO this past year on the overall survival. This is out of a phase 1 trial. These are pretty heavily pretreated patients, kind of similar to VISION. VISION, the overall survival at median was about 15.3 months. Here, she's reporting median overall survival of 33 months, so it's like double, which really got my attention. It's quite good. And we're now playing around with this in the clinic. Problem is the PARP inhibitors are expensive. We don't always have access to them. But the preliminary data with the PARP plus lutetium is outstanding. So we need to pay attention to that. There's also preliminary data that the antigen release from radiated tumors may be important in activation of the immune system. And there's a little bit of data where you combine the single-dose lutetium followed by pembrolizumab and being able to show that the outcome, at least by PSA waterfall plot, is good. We still need randomized studies here, but some people believe that the immunotherapy combination with lutetium or other isotopes could be quite good. So we just need to get more data. Alpha particles. So what I've talked about so far are the beta particles, which are basically like little electrons. It turns out that alphas are basically a helium nucleus. They're 2 protons, 2 neutrons. They're about 7,000 times heavier than an electron, and they travel pretty fast. The electrons are going almost the speed of light, so they're flying off. Those beta particles are coming off the speed of light. Here we're talking about 6% of the speed of light, and it packs a fair amount of energy. It's like a little nuclear bomb going off. And it turns out that they don't go very far, so the alpha particles really only go microns as opposed to kind of millimeters for many of the betas. And they pack a wallop, and they cause a lot of DNA double-strand breaks, which are hard to repair. So a lot of people are putting alpha particles at the center of their strategy. There are 3 alphas that are chelatable and being used as astatine-211, lead-212, and actinium-225. Radium-223 is Xofigo, FDA approved, but it's non-chelatable, so we can't use it in the targeted alpha therapy that we want to. By the way, a nice targeted alpha therapy conference in Brazil next month. We're going down, all the targeted alpha therapy people will be down there. I get to go down there to Rio and enjoy part of that part of the world. This is, obviously a case report. It's not a clinical trial. But here's a person with a PSA of 2,900. They've gone through, every treatment you can imagine except for the lutetium-177. Go on actinium and get a complete remission. And, some of these patients have outstanding responses. So as we go forward, we need to pay attention to this. This is a provocative study from Seth Gay out of Pretoria, South Africa, and that's a PSA waterfall plot, just giving the actinium with no hormonal therapy. This is just actinium with no hormones, and you get that kind of PSA waterfall response. So people are excited about this. This is a ESMO 2025 presentation with lead-212, a little company out of Australia called AdvanceCell. They have a really good waterfall plot for phase 1, so they're now expanding this into phase 2 and thinking about phase 3. But lead-212 is definitely an active agent, and it's an alpha particle. If we look at the current commercial programs with alphas, Convergent, which is small biotech up in Boston. AstraZeneca is about to launch a phase 3. Telix has got one underway. Bayer is planning a phase 3 with something called Trillium, just presented at the ASCO GU in San Francisco 2 weeks ago, 3 weeks ago, whenever it was. Novartis has 2 phase 3s that are already up and running. ITM is moving forward. One called Full Life is moving forward. ArtBio, Viewpoint, AdvanceCell all have lead-212s. Another one, astatine-211, is moving forward with a company called Z-Alpha. So lots and lots and lots of commercial activity ongoing here. But the Novartis is in the lead with 2 phase 3s actually underway. So that's important. One of the things that's a little bit of a problem, and I talked about the way isotopes can overcome heterogeneity, and they can, but a lot of the cancers that are actually killing people are not even expressing PSMA at all. And this is a problem because if we don't target the cancer cell, we're not going to be able to come forth and benefit the patient. So this is an autopsy study at University of Washington in Seattle, and basically showing that even though PSMA is positive, it's not positive in all the patients. So we need more. So currently we're thinking about targets beyond PSMA. And there are a whole list of them here, B7H3, HK2. HK2 is also known as KLK2, kallikrein-2. And that's a really good target. J&J is targeting that with so-called pasritamig, which is their T-cell engager. Anyway, provocative data there. They're now in phase 3. STEAP1, STEAP2. STEAP1 is in phase 3 with the T-cell engager. STEAP2 is being explored by AstraZeneca with radiopharmaceutical. B7H3 is coming out from a couple of different angles. One called Mariana is about to go, and there's another one with Actis, AKTIS, that's going. DLL3, which is neuroendocrine, CEACAM5 is being looked at, HER3 is being looked at, GRPR is being looked at, TROP2. ACP3 is acid phosphatase, and that's a pretty good target. There's more than one company going after it. And BMS paid a bunch of money to get a ACP3 targeted agent through RayzeBio. They're going to be pushing that forward. FAP, which I didn't talk about, which is fibroblast-associated protein, is a stromal target that's moving forward, and so is LRRC15, which is moving forward, another stromal target. So lots of stuff. And all of these can be imaged with PET/SPECT, and all of these are kind of targeted therapies. There's activity, both either preclinical or clinical, for all of these molecules right now. So what we're seeing now is the tip of the iceberg. Where do we go from here? Different targets taken in PSMA, yes, but also improving upon PSMA. I've seen a new PSMA ligand that is extremely attractive, probably could be able to beat the Pluvicto. Different isotopes, both the actinium, the lead-212, terbium-161, in addition to the lutetium. Lots of combinations, hormones and isotopes like the ENZA-P trial, immunotherapy with the PD-1 inhibitors like Pembro, DNA repair inhibitors like the PARP inhibitors, radiation sensitizers, chemotherapies, all of these combos are moving forward now. Earlier stage of disease, like the PSMA-DC trial, the oligometastatic PSMA PET positive, and of course, all I've talked about is prostate, but every other cancer, whether it be ovarian or uterine or cervical or lung or GI, colon, pancreatic, there are programs just all over the place. So, watch this field. It's developing incredibly rapidly. And I'm predicting there'll be many FDA approvals in the years ahead. And with that, I'll simply say that one of the things that attracted me to this field is the ability to overcome the heterogeneity of the underlying cancer cells. If you look at the genetics, it's all over the map. We have everything from APC mutations to BRCA mutations to mutations, EGFR, you name it. Mutations are all over the place. But radiation doesn't really care. Radiation can kill them all. It's not precise therapy, it's imprecise therapy, but can overcome the heterogeneity that we face in the patients we treat. And with that, I'll say thank you. Thank you very much, Pia. And enjoy it. I'm going to sit up here.
Thank you so much, Dr. Sarda. That was really great to hear what's coming down the line with these new radioligand therapies. It's my pleasure to introduce our next speaker, Dr. Patrick Pilier. He's associate professor in the Department of Genitourinary Cancers at MD Anderson Cancer Center. But even more importantly for those folks of you here in the room today, he is a New Orleanian. So if you need to find directions later on, we can applaud. He knows how to pronounce Tchoupitoulas, and I did not have to explain what a second line was to him earlier today. So that's good. But seriously, he's a real leader in prostate cancer research, particularly looking at drivers of treatment, molecular drivers of treatment response and resistance, particularly DNA damage response pathways and how we can target them in clinic. He serves as the principal investigator in multiple major medical grant funding grants, including he's got a DoD grant looking at DNA damage response pathways, how that drives heterogeneity in androgen receptor response, along with an R01 in non-invasive biomarkers to guide use of combination PARP inhibitors with androgen receptor pathway inhibitors. More importantly, it's not just translational work that he does. He also leads a project looking at improving uptake of germline genetic testing for patients in a diverse safety net hospital, a real point of need that we know that we're lacking here in prostate cancer care. And he's a sought-after speaker, over 17 national and international presentations, over 50 peer-reviewed publications. So his work really spans the gamut from translational research, clinical care, advocacy, and education. We're really thrilled to have him here. Please join me in welcoming Dr. Pilier.
Thank you so much for the introduction. Thank you to the committee for the opportunity to speak to you today. And this is my first time attending a CAGLA conference, so a big thank you to Chad and the entire committee for what you do for all of my family and friends in the New Orleans and Louisiana area. So thank you on multiple accounts. So today, an overview of combining anti-androgen therapy and radiation. And at the heart of the talk is the question of, is more always better for our patients with prostate cancer? briefly disclosures that are not pertinent to today's talk. So I start out with a patient case, a patient that I saw a few years back and continued to follow in the clinic. A 63-year-old man referred to the clinic in medical oncology, had a history of prostate cancer, a high-risk disease, Gleason 4+5=9, underwent prostatectomy, had some adverse pathologic features, and went on to receive salvage radiation therapy with 6 months of androgen deprivation therapy. At the time of salvage radiation therapy, his PSA was 1.6 prior to initiation of ADT. And I met him after that. He had achieved undetectable PSA in 2020, and a few years later had his second occurrence of biochemical relapse in the post-radiation setting. Of note, his past medical history had some cardiovascular disease, as most of us do, and a remote history of seizure. He also, first visit with him, expressed his strong desire to avoid any future use of androgen deprivation therapy where possible, particularly prolonged use of androgen deprivation therapy, which is a refrain I hear day in, day out in the clinic from my patients. And the PSA trends, as you can see when he presented to the clinic. So we're going to come back around to this patient case at the end of the talk. So very quickly, just a historical overview of the combination of androgen deprivation therapy and radiation in prostate cancer. Going all the way back to the 1940s, all these gentlemen here might look like a panel of our patients that we see in clinic for prostate cancer, but they are actually the pioneers in their respective fields of discovering the suppression of androgen and its relationship to treating prostate cancer with Dr. Huggins, Dr. Shaley, and the chemical castration development, Dr. Walsh in surgical approaches, Dr. Bagshaw in radiation and its treatment in prostate cancer, and Dr. Murphy, medical oncology, and the use of chemotherapy. So we initially saw the improved outcomes, improved overall survival in locally advanced prostate cancer with the combination of long-term androgen deprivation therapy and radiation therapy all the way back in 1997. We then had a pretty long gap with any further developments. And then over the last 10 years, with both androgen deprivation therapy, radiation therapy, and as Dr. Sartor is a leading world expert in PSMA-targeted and other radionucleotide therapy, really over the last 5 to 10 years has been a flurry of activity that has rapidly changed the field. So in terms of the biology of why we would combine androgen deprivation therapy or anti-androgen therapy with radiation, there's a few different domains where they interact, including both spatial cooperation and systemic disease control that we kind of lump together, where it's just the basics of anti-androgen therapy can kill androgen-sensitive cells, radiation therapy can kill radiation-sensitive cells. So you have two mechanisms of action of cell death and cell killing, so they complement each other. And then the systemic control of micrometastatic disease, particularly in the era of conventional imaging, before PSMA PET scans, androgen deprivation therapy can control micrometastatic disease outside of the immediate radiation field. And then there is biological sensitization, where we know from multiple studies that anti-androgen therapy does downregulate key DNA repair pathways, sensitizing prostate cancer cells to the effects of DNA damage from radiation. And then just simple volume reduction. So the use of anti-androgen therapy reduces the primary tumor volume significantly, allowing for dose escalation of the radiation within the normal surrounding tissue constraints. Central question, though, currently is, with advancement in systemic therapies, anti-androgen therapies, targeted therapies, second-generation ARPIs now available, how can we intensify therapy further, and for which clinical scenario does intensification make sense? Does it actually improve outcomes? And for which clinical scenario does it actually maybe not make sense and we can spare long-term castration? So starting out with radiation and combining anti-androgen therapy in the primary setting. So patients with high-risk localized prostate cancer. The STAMPEDE study that I'm sure many are familiar with, but is probably the single most impactful study to date in prostate cancer. Multi-arm study, multi-stage, looking at very different treatment platforms. But a key comparison is comparing androgen deprivation therapy versus combined abiraterone acetate and androgen deprivation therapy, and another arm that combined abiraterone acetate, ADT, and enzalutamide versus androgen deprivation therapy alone. And this is highlighting the high-risk localized non-metastatic cohort, where we see both failure-free survival and overall survival benefit, hazard ratios of 0.29 and 0.6, with the overall survival curve here on the bottom for the non-metastatic population, that the addition of second-generation ARPI significantly improves metastasis-free survival and overall survival above ADT alone for 2 years in patients with non-metastatic high-risk localized disease. The study did show that there was no additional benefit from adding enzalutamide into the mix with abiraterone. And on the flip side, the study also looked at patients with metastatic disease receiving abiraterone acetate and ADT, and whether or not radiation to the primary improved outcomes in these patients. And indeed, as seen on the right with the hazard ratio of 0.60, that radiation therapy to the prostate did improve overall survival in the low burden metastatic disease patients. Hazard ratio there, 0.68. There was no overall survival benefit, though, seen in this study in higher burden disease. And so site selection is really critical in this definition of what is low burden disease. This was based on conventional imaging, and it was less than 4 bone metastases with no visceral metastases. So now with updated studies, as were mentioned in the prior talk and others, with modern PSMA PET imaging, this data is actively evolving. So to summarize STAMPEDE, and the high-risk definition here was greater than or equal to 2 of multiple adverse features, T-stage, Gleason score greater than or equal to 8, PSA greater than 40, or node-positive disease. So this is technically by our NCCN guidelines very high-risk disease. But as you can see, metastasis-free survival, overall survival, biochemical failure-free, significantly improved with the addition of ARPI, with the hazard ratios listed, without a lot of added toxicity. Important caveat, though, again, STAMPEDE used CT and bone scans, not PSMA PET. So many of these non-metastatic patients by conventional imaging likely would be restaged as oligometastatic disease on PSMA PET. So in a brief summary, who should receive this combination therapy? High-risk criteria, node-positive disease, but questions, how is PSMA PET going to change this, as who's qualifying as high-risk non-metastatic? And the role of other ARPI agents, enzalutamide, apalutamide, darolutamide. There are studies ongoing in the high-risk localized setting. And then also the optimal ADT duration when we have ARP added. This was STAMPEDE, 2 years. There's data for 18 months. And other studies that have shown when using in combination, we might spare patients longer-term castration by adding in the ARPI in this finite duration. With STAMPEDE establishing kind of new standard of care and benefit for close to 80% of patients with high-risk localized disease, there's still unfortunately the 20 to 30% of patients that progress even despite the addition of ARPI to develop metastases within 5 to 7 years from their primary treatment. And so these studies, we developed a study here, but there are many others that are looking at baseline, at diagnosis, what are the indicators of a patient's prostate cancer having the highest risk of coming back down the road. And so this was on top here, a pre-surgical study that gave patients 6 months of ARPI and ADT before undergoing prostatectomy. They all had high-risk localized disease. They all essentially achieved an undetectable PSA at the time of their prostatectomy. However, on pathologic review of the prostatectomy specimens, approximately 30 to 40% of these patients had adverse cellular features indicating a less sensitive response to anti-androgen therapy. And those patients with these adverse pathologic features had a 60% relapse-free survival compared to those patients who had a very, very good response to the anti-androgen therapy in the tumor, almost 90% relapse-free survival at 5, 7, and longer-term follow-up. So that led to the design of a study actively ongoing and almost complete, where we give patients a 3-month course of combined ARPI with apalutamide and ADT, and then have the patients undergo a prostate biopsy to look at these pathologic response features to the anti-androgen therapy and escalate therapy in patients where it makes sense, where they're having a less favorable response, and leave the patients alone, not add toxicity for those that are predicted to have a very good outcome from gold standard anti-androgen therapy alone. So now moving on from the primary setting to the post-operative setting and salvage radiation setting, 20 to 40% of men undergoing radical prostatectomy with high-risk disease will experience biochemical recurrence, and that post-op radiotherapy does improve survival, but the question still remains, who needs anti-androgen therapy, who needs ADT, and for how long? So current guidelines of when ADT is added to salvage RT, based on AUA, ASTRO, SUO, recommend ADT with high-risk features. And so what are these high-risk features? A PSA greater than or equal to 7 at the time of salvage, higher Gleason grade group, PSA doubling time less than or equal to 6 months, and a persistently detectable post-op PSA with other adverse surgical features like seminal vesicle involvement. And then if there's lymph node involvement, always add ADT. But there was a recent, just presented at GU ASCO and published in Lancet last month, Poseidon study, where they did a large meta-analysis of over 6,000 patients from 6 phase 3 randomized controlled trials with a median follow-up of 9 years, looking at patients in the post-operative setting, range of Gleason scores, surgical margins, how these studies were designed. Although, should mention, these studies are all pre-PSMA PET era, so these are all based on conventional imaging, biochemical recurrence salvage radiation setting. The trials that were included in the meta-analysis are listed here on the right, and they looked at primary outcomes of overall survival and then a secondary outcome of metastasis-free survival. And what they found was, looking at the population as a whole, that there was no signal for benefit in the overall population for the addition of androgen deprivation therapy, whether that be long-term or short-term. With the hazard ratios listed here of 0.87 of hormone therapy plus post-operative radiation versus post-operative radiation alone, you can see just crossing the threshold p-value of 0.06. And looking at metastasis-free survival of HT plus port versus port alone. 10-year overall survival, 84.3 versus 83.6%, and metastasis-free survival, as you can see here on the far right. So overall study population doesn't look like adding hormone therapy in the post-operative setting for radiation really adds much, but when they break down into subgroups, so looking at particularly PSA at the time of radiation, there was a suggestion from the study that higher PSA levels do benefit from the addition of androgen deprivation therapy with radiation therapy at the time of salvage radiation therapy. So there, potentially some PSA threshold for benefit to the addition of hormone therapy in this postoperative setting. In terms of the duration of hormone therapy in the postoperative setting, there was no significant interaction by duration, and so short-term hormone therapy is sufficient for the majority of patients, was their overall summary. And so practical clinical applications from this large meta-analysis, I still think the question is out a little bit in terms of who needs hormone therapy and how long. And particularly in our modern era of PSMA PET imaging, the applicability here becomes a little harder to implement, directly in the clinic. And so just a schema down here from their paper, kind of summarizing how we use this data, where the pre-radiation therapy PSA less than or equal to 0.5 or greater than 0.5 can help sort of make that decision of the benefit of adding hormone therapy. But again, we are in a different era. Now, most patients will have PSMA PET imaging, a biochemical recurrence. And so it's a real paradigm shift in terms of rising PSA with negative conventional imaging and no detectable disease, is that PSMA PET scans are picking up 40% or more of those previously called biochemical recurrent, but now oligometastatic disease, with a 90% detection rate if the PSA is 2 or greater versus just 44% with CT and bone scans, close to 60% versus 40% overall detection rate of PSMA versus conventional imaging, and 62%, PSMA PET leads to 62% change in management in these biochemical recurrent patients. And so it's really reclassifying the disease stage actively, and so using data from the conventional imaging era is a little hard to do, because 30% of biochemical recurrent post-RP patients are going to have oligometastatic disease on PSMA PET. So practically non-metastatic BCR by CT bone scan that was included in the meta-analysis and other studies predating PSMA PET is actually a good percentage oligometastatic disease or more on PSMA imaging. So some clinical implications of this, combining sort of the data from the meta-analysis Poseidon and our kind of modern imaging practice in the clinic, is that negative PSMA PET scan still is not recommended, that you should delay salvage RT if it's otherwise indicated, that PSMA positive findings outside the radiation template can guide directed therapy, SBRT. Oligometastatic disease, which we'll come to next, opens the door for metastasis-directed therapy and systemic therapy. And then also, which we'll end on, is there are many patients that would qualify for an EMBARK-like strategy that was conventional imaging based that likely have PSMA detectable disease. So how we practically use this in clinic is a evolving target. So this is just highlighting PSMA PET detection rates by PSA level, again, redefining non-metastatic disease, where we see, particularly in this range of 0.2 to 0.5 and up to 1, stark differences. And so in that Poseidon study, their PSA cutoff of 1 or greater, 0.5 or greater, is that a majority of those patients probably do have PSMA PET positivity that wasn't assessed on that study. So, how has PSMA PET transformed biochemical recurrence into oligometastatic disease? It's this intermediate state between localized and widespread disease. It's typically defined anywhere from 3 to 5 metastatic lesions, first proposed in 1995 with conventional imaging, but PSMA PET has dramatically expanded this. And so, there's a few different ways it is actively impacting the field. I won't harp on this further, but PSMA PET revealing that 30 to 40% of post-RP biochemical recurrent patients actually have oligometastatic disease. It's actively changing management. We need more studies, and they're actively ongoing, and we'll read out. But just an example, it's now possible to target individual metastatic deposits with SBRT omitting unnecessary pelvic or prostate bed radiotherapy and potentially omitting systemic therapy, as was mentioned in the prior talk of a couple ongoing trials. So just highlighting here, Oriole, ongoing trial is metastasis-directed therapy for biochemical recurrent disease that is PSMA PET based, and it is observation versus site-directed therapy with metastasis or progression-free survival as an endpoint, and see significant differences when we use PSMA PET to guide site-directed therapy. So new clinical challenges, should we add metastasis-directed therapy to systemic therapy for everyone? Can metastasis-directed therapy actually allow for de-escalation, shorter time on castration, and is salvage prostate radiation therapy to the bed even needed when PSMA PET shows only nodal or outside of the bed activity? And so this is just highlighting one trial in the oligometastatic setting, the EXTEND trial, combining radiation therapy and hormone therapy for oligometastatic disease. It randomized patients to intermittent hormone therapy versus intermittent hormone therapy plus site-directed therapy by conventional imaging. And it, along with other contemporary trials of site-directed therapy, have shown that it significantly improves progression-free survival. It improves also eugonatal survival, meaning time off of castration for patients with a mostly chronic disease. Some limitations: this was a phase 2 trial. It used primarily conventional imaging, and intermittent ADT wasn't standard in all our guidelines. So larger confirmatory trials are ongoing. So just to summarize some of the oligometastatic disease trials currently combining SBRT and systemic therapy. Again, Oriole, SBRT to all lesions versus observation, benefit in progression-free survival and disease control. The STOMP trial, it's a phase 2 randomized control trial in hormone-naive oligometastatic BCR, metastasis-directed therapy again versus active surveillance. It delays the need for ADT initiation. Real-world data coming from apalutamide and site-directed therapy in MHSPC. It's actively being practiced. Prospective data is growing. Again, PFS benefit and time off therapy. And just a list of some ongoing key trials in this space that we'll be reading out very soon. So the field and the trials currently are all geared towards PSMA PET-guided precision site-directed therapy plus or minus systemic therapies. And lastly, the data from EMBARK. So patients who have had biochemical recurrence, had salvage radiation therapy, and had biochemical recurrence yet again, like the patient mentioned in the case at the beginning. So EMBARK looked at high-risk biochemical recurrence post-radiation therapy and randomized patients to receive enzalutamide plus Lupron versus Lupron alone versus enzalutamide alone arm. And the short of it is that there is significant metastasis-free survival and overall survival benefit for the combination of enzalutamide and ADT versus ADT alone. And there is significant metastasis-free survival benefit with enzalutamide alone, although OS benefit not yet seen. EMBARK enrolled via conventional imaging, very importantly, and many patients, again, likely have a PSMA PET detectable disease, so how we incorporate this into the clinic, again, is a bit of a moving target. Does adding radiation therapy to enzalutamide in EMBARK eligible patients add further benefit? So site-directed therapy in a patient on enzalutamide alone. But EMBARK establishes enzalutamide and ADT as a new standard for high-risk biochemical recurrence, post-RP and post-RT. So this is the 5-year metastasis-free survival of the combination versus enzalutamide monotherapy versus leuprolide alone. And many, many patients, again, are requesting the sparing of castration. So this is a new option for many of those patients. So in summary, is more always better, kind of a framework for how we can use this data in the clinic. Pretty clear that in high-risk, localized, locally advanced disease, yes, not only ADT, but the addition of ARPI. In terms of the length of time needed for those, that is still under investigation. In terms of low-burden metastatic disease, again, yes, RT to the primary does improve overall survival when combining with gold standard anti-androgen therapy. The question mark that remains uncertain, and with the recent Poseidon data and with ongoing data in the PSMA PET era, is whether in this biochemical recurrent post-RP setting does it make sense, and likely no, not for every patient, not for a blanket approach, that we need better biomarkers and better strategies to select patients for who warrants escalated therapy and who actually may qualify for de-escalation. So some take-home messages: combining anti-androgen therapy and radiation is foundational. Decades of evidence to support its use in the advanced and local disease settings. And so question is now, which agents for how long? STAMPEDE really set the new standard in the high-risk localized setting. In the salvage setting, data is evolving, and how we implement this in clinic really still needs to be kind of patient-to-patient dependent. And combining site-directed therapy in PSMA PET era is significantly improving outcomes. So back to the patient case, just to quickly summarize, he did not have a PSMA PET at the time of salvage RT, so we don't know if he had oligometastatic disease at that time, but he did get a PSMA PET at the second recurrence, and he had 3 asymptomatic bone mets, and he elected to proceed with ARPI alone, it shouldn't say plus ADT, with site-directed therapy to those sites, and he currently is on surveillance. PSA is undetectable, and testosterone is non-castrate. So happy to take any questions, and a big thank you again to the organizers for the opportunity to speak. And this is my kids at Mardi Gras this year. Thank you.
Thank you so much, Dr. Pillay. I think your talk really raises a question that we face, a clinical problem that we face in practice, which is how long and how much to give. So it's my pleasure to introduce our next speaker, who again needs no introduction, Dr. Brian Halbert, who many of you know either from Ochsner or from CAGLA community. Dr. Halbert is a staff physician in the GU Oncology at Ochsner MD Anderson. There he leads the Advanced Prostate Cancer Clinic and spends his days in the trenches, really managing complex prostate cancer cases, which we see a lot of here, and thinking about how we actually deliver modern treatments and the next generation of treatments to patients in the real world. He's been doing very thoughtful work in this space, including a project through the Alliance looking at home health monitoring for prostate cancer patients, and an American Cancer Society funded initiative focusing on expanding PSA screening and treatment access to the river parishes. So not just studying disparities, but actually trying to fix them. And as we all know, we happen to live in Cancer Alley in this area, so this is very relevant work. So please join me without further ado in welcoming Dr. Brian Halbert, who will be speaking on Bridging the Gap.
Thank you guys so much. I always enjoy coming to CAGLA every year. It's fantastic. Agreeing to speak after Dr. Sartor and Dr. Pillay, I'm not quite sure what I was thinking this year, but we'll make it work. It also occurs to me, I think we're going to be doing a roundtable afterwards, and I see one microphone, so I wonder if we can get that same handheld microphone that the general was using earlier. It's over there. Okay, good. Well, I'd really like to thank our previous speakers, really doing a great job of setting up some really cool things that we are doing in cancer clinics for what we can do for our patients, particularly with radioligand therapy, what we should be doing for them in regards to radiation therapy and androgen deprivation therapy. But I want to take the talk in a little bit different direction and not think so much about what we can do, but really start thinking about how we can do it, and how we can do it in a way that's going to deliver equitable results for all of our prostate cancer community. I do have some disclosures. I do some ad boards. I also have to disclose that I did use ChatGPT to come up with my title, but I do promise the rest of this is going to be me and my sources. A couple of objectives that we have here today. Sure, you want to just use this? This is working? No? Okay. I can stay back here. We should just get this working for the round table. We'll put it there. All right, so a couple of objectives here today. First thing, I really want to make sure that we review the current state of disparities within prostate cancer. We know they're there. We see them, we feel them in clinic every single day. I want to think about what goes into implementing a radioligand program and what sort of barriers may exist as we try to ramp up these treatment strategies throughout the country. And then hopefully I'd like us to at least start to think, particularly the people here in this room and the people within CAGLA, what kind of ideas can we come up with to start to address some of these barriers as we start to use more and more radioligands. This slide is just basically to remind you of everything that Dr. Sartor was just saying. Radioligand therapy is here in prostate cancer. It is not going away. We are only going to see it more and more and more, not just in prostate cancer, but also throughout other cancer types, not just in post-docetaxel castrate-resistant disease, or we're going to be seeing it in earlier disease space. This is going to be more and more patients being treated with these drugs over the next several years. So we have to be very intentional with how we utilize or how we build out our programs so that we don't exacerbate current disparities that we see. This is really what got me thinking about this. And if there's one slide in this deck that's going to get me in trouble, it'll probably be this one. But I'm hopeful that if you guys follow my thinking on this, we won't necessarily come across this as being particularly controversial. Okay? I don't know how many of you guys are familiar with the man over here on the left, but that's Scott Adams. He became moderately famous decades ago as the creator of the Dilbert comic strip. It's a good strip. I remember reading it growing up. Really lampoons office culture in the country. Later in life, he also became moderately famous for being particularly outspoken on social media with certain, kind of conservative firebrand politics. Really was kind of plugged into the Twitter sphere of the political moment. During this timeline, though, he was also suffering from prostate cancer. And late last year, it was decided that he might benefit from Pluvicto, and he was trying to get access to the drug out in California. And I don't know what happened, but apparently he had some trouble getting access to it. And so he utilized his connections in the social media world, and he tweeted out directly to the President of the United States and to several top administrative officials saying, hey, I need some help here. I need help getting this drug. And, social media being what it is, he got response in, minutes. He got the Secretary of Health and Human Services saying, we're on it. We're going to get you this drug. We're good to go. At the same time, many of you might recognize this quote over here on the left. This is from the New Testament. It's from Matthew 25. And it's one of Jesus' most famous parables. And really what it is telling us is that, or at least for his disciples, we're not going to be judged necessarily by how we treat our friends and the most advantaged and the rich in this world. But when it really comes to our judgment, we are going to be judged by how we treat those who are the least advantaged. Okay? So I don't think it's particularly controversial to think about that, personally appealing to the President of the United States to get access to health care is not scalable. And it's not really indicative of a healthcare system that's functioning the way it should be. I also think that regardless of where you're coming from a moral or ethical or religious bend, that we should judge our healthcare system on not how it treats the most advantaged and the rich, but how it treats the least advantaged of all of us. And we know that prostate cancer is not, the burden of prostate cancer is not shared equally. This here is data looking at the incidence of prostate cancer diagnosis by race in the United States. And then on your right is the incidence of prostate cancer mortality in the United States. And if you look at it, I don't know where my pointer is here. Well, suffice it to say, if you have 100,000 men, 188 black men are going to be diagnosed with prostate cancer compared to 113 white men. But even more striking is within those 100,000 men, I think I can't quite read it, but it's like 36, I think, of those black men are going to die of prostate cancer compared to about 17 for white men. Black men are more than twice as likely to die of prostate cancer than white men in this country. And this led to one of the more provocative JCO editorials that I had seen in the last several years. This was published a couple of years ago, and it says, racism does not cause prostate cancer, but it causes prostate cancer death. And the point of the authors in this article wasn't necessarily to be particularly controversial or provocative, but what they were really getting at was this gap in prostate cancer mortality cannot be entirely talked away by diagnosis and genetics and biology. But there truly is something baked into our healthcare system that is leading to unequal outcomes for our patients. Now, the root cause of healthcare disparities is clearly across the entire gamut of public health. That's more than I can talk on in a lifetime, right? And as physicians, we're typically focused kind of on the bottom part here of this here, the healthcare system. But if we really want to make sure that we're giving the best care to all of our patients, it would be folly of us to kind of turn a blind eye to these other sorts of issues that we have to think about. And if we're policymakers, or if we're talking to policymakers, we also have to make sure that they are addressing all these other sorts of issues that we're looking at. Economic stability, are we giving good jobs to our entire community? Food security, do we have access to good health and nutrition, particularly for the kids amongst us? Do we have good community and social support within our communities? The built environment, access to playgrounds and green space is very important for public health. And then education. We need to be providing high quality education so patients can have the health literacy to help take care of themselves. And then of course, healthcare systems, which is kind of what we're going to be talking about a little bit here, therein. So where are we right now in prostate cancer disparities? Well, this looks at some of the disparities in prostate cancer diagnosis. So despite the fact that black men are diagnosed usually at an earlier age and more advanced stage, they are less likely to get PSA screening tests than white men. This is over here on the left with the percentage of white men having a PSA screening test in red and black men in blue. And then once you're going to go for your biopsy, what's the likelihood of receiving advanced imaging with MR targeted biopsies before getting your prostate biopsy? It's considered, we consider that to be a best practice. You can see over the years that has been going way up, but it's not equal between the races. In white, I don't think it says it there on the screen, is the percentage of white men getting an MR targeted biopsy versus black men. What about disparities in treatment? Well, we know that race is included. Black men are less likely to get definitive therapy for prostate cancer once they're diagnosed. But it also goes across not just race that we're looking at, it's also socioeconomic status. If you have lower socioeconomic status, you're less likely to get radiation therapy or radical prostatectomy. Geographic disparities are very real. People in rural settings are less likely to get guideline concordant high quality care than those of us in urban centers that have access to academic centers. Travel distance is a big issue for these patients. Insurance status. If you have a good, high quality private healthcare system or healthcare payer, you're much more likely to get definitive treatment, and patients on Medicaid are more likely to be diagnosed with more advanced disease. This is kind of an old slide looking at access to PSMA PET imaging. This was published back in 2023. So this was just simply like pointing a little on a map of where there's PSMA PET imaging that's available. I certainly hope this looks a lot different today because I think Denver has probably gotten access to a machine by now. But still, it does show you how, whenever we roll out new technologies like this, they really do tend to be clustered within certain geographic areas, and we need to think about how can we not create more of these disparities. And finally, there's a very real element of distrust within the medical system from some of our in certain communities. I do a lot of kind of community events looking at screening awareness within the community and trying to get guys out there to get tested. Talk about enrollment in clinical trials is a big thing that we talk about. And one thing that always comes back to us whenever we do these events is people want to talk about the Tuskegee untreated syphilis study. So this is a picture there from U.S. website showing that the United States Public Health Service from the 1930s to the 1970s conducted a longitudinal study in black men from Macon, Alabama, who were diagnosed with syphilis. And they did not tell them that they had syphilis. They did not tell them that they were in a research study. And they didn't tell them that there was treatment. And they didn't treat them. And that has left an indelible mark on the amount of trust that we have in the healthcare system for many patients. And that's real. Not only that, but the workforce of the physician workforce in this country does not adequately represent the communities that it treats. This country is about 14% black, but only 5% of the physician workforce is black. So we need to think about how we can make it more representative of who we are treating. As a result, you see things like black men are more likely to report distrust in the medical system, and they're more likely to report poor communication with their healthcare providers. But we know that if you put patients into an equal access environment, these disparities disappear. So it's not that certain men are just they're just more likely to die of prostate cancer. No, if you give them an equal opportunity, people do just as well. And so if you look at this is a forest plot looking at the prostate cancer specific mortality. On the top is the SEER database, so that's just the real world data showing that black men are more likely to die of prostate cancer. But if you put them in the VA system or if you put them in a randomized controlled clinical trial, we see that mortality discrepancy disappear. So that's where we are with discrepancies in the country today. But let's think about what we can do to implement radioligand programs so that we don't continue to worsen these sorts of disparities, and what goes into the development of a program. It's complex. I mean, I as a medical oncologist, coming out of fellowship several years ago, I was fairly naive in the ideas of what really goes into making a radioligand program. And so over the last couple of years, we've really had some experience in figuring out where those pain points are. So first of all, regulatory burden. I mean, if you think about it, we're infusing patients with radioactive material. I mean, I guess if anything needs to be carefully watched over, I guess that is one of those. But there are several overlapping bodies that regulate the radiopharmaceutical industry. There's obviously the FDA, who's responsible for approving new drugs, but the licensing and use of these radiopharmaceuticals is regulated by the U.S. Nuclear Regulatory Committee. And then there's other layers where certain states may have state bodies that are involved in the regulation. There are certain agreement states that have signed contracts with the U.S. federal government that says that they can regulate it. I believe Louisiana, we are regulated through the Louisiana Department of Environmental Quality, which sounds very efficient to me. But this sort of radio bureaucracy is very real. And going through the sorts of hoops to get licensed can take, not just months, but sometimes it can take, a year or two. Additionally, I like to think that, oh great, I'm giving my patients radioligand therapy. I am not giving my patients radioligand therapy. I am not an authorized user. So, my name is not on any kind of radiopharmaceutical licensing. You have to have, for the a radioactive material license, you have to have an authorized user. That means, federally mandated training requirements for use of radiation material. Typically, these are going to be your nuclear medicine doctors or your radiation oncologists at your site. Speaking of which, you have to have a very complex, multidisciplinary team. So again, I kind of think of myself as, the top of the food chain as the medical or the clinical oncologist in this setting. But, in this setting, no. I mean, you've got the authorized user within the nuclear medicine department that's going to be doing this. You need the radiopharmaceutical technicians or the nuclear medicine technicians who are actually in the room with a radioactive material, infusing it into patients. You have to think about maintaining their safety for sure. You've got radiation safety officers who have to put together plans for the entire healthcare system to think about what do we do when that radioactive patient walks into an emergency room and you've got a pregnant nurse who's going to try to take care of it. How do we prevent that? How do we prevent harm in those settings? Nuclear physicists and nuclear pharmacists, and then finally things like scheduling coordinators and nursing. These are inherently settings that you're going to be taking in patients from a variety of systems and clinics, and how do you seamlessly integrate them into your radioligand program is something that you really seriously have to think about. Physical infrastructure is certainly something that I hadn't thought about as a medical oncologist, but if you look at the physical space that's required for these programs, you have to build out a hot lab that's sufficiently big enough to hold these materials. And so you start talking to these areas and well, we just don't have anywhere to hold this stuff. And well, can you just build it? Well, it takes investment. You have to have, an appropriate treatment area within the nuclear medicine suite that's got appropriate lead shielding. And, think about where the patient's going to be sitting there and maybe put some additional lead shielding behind that area. Bathrooms are something that comes up a lot in the nuclear medicine suite because, if you have the patient going to the bathroom afterwards, you got to think about decontaminating that entire bathroom. So these are real physical environment things that have to be thought about as you're planning out one of these programs. Supply chain. For those of us who are trying to give Pluvicto commercially in 2023, we know how sensitive the supply chain is for these sorts of medications. This isn't a pill that sits on a shelf in a pharmacy somewhere and has a shelf life of God knows how many years. These are, materials. They come from rare earth metals. So the next time you're listening to the news and, rare earth metals comes up and you're like, well, that doesn't really affect me. Yeah, it does. And it affects your patients. It's got to be made in a nuclear reactor. That's got to be sent directly to that patient. I mean, these things degrade over the course of a couple of days. So very, very sensitive supply chain issues. In 2023, right after Pluvicto was approved, there was significant disruption in the supply chain, which fortunately, took, 6 to 12 months to really kind of get through. But it was a really difficult time to get patients into treatment, and something that really reminds us of how sensitive these supply chains are. And then finally, as I was kind of saying, patient navigation is important. How do we get patients not just from, my clinic or my colleagues' patients, but, from across the city, across the state? How do you get them to where they need to go in patient navigation? So what kind of things can we do to improve care for men with castrate-resistant prostate cancer or, men getting radioligand therapy in different settings? Well, one, we just need to optimize treatment upstream of radioligand therapy. We know that far too many men, particularly in this state, are not getting optimal, treatment for hormone-sensitive disease. There's estimates that up to 20 to 60% of patients may not be receiving appropriate doublet therapy in the sensitive disease space. I think you guys heard Dr. Matrena mention earlier that we're going to be doing a little closed-door session talking about, some results of some surveys that we did through the Louisiana Cancer Endowment. So we'll be interested to see what that shows. But definitely think about how we're treating, upstream of the radioligand program. We need to rebuild trust within our community. I think regardless of what system that you're involved with, I think we all got into medicine to try to help patients. And making sure that, your institution is really trying its best to engage with the community, go to those, health fairs and really listen to your patients, get out into the community. This is from the Ochsner Community Benefits Guide, one of the PR things that we like to put out, talking about the different health fairs that we did in combination with some pharma partners in trying to get words out at, Zulu. I think we were using different churches around the area, all sorts of stuff. And of all the things that we've done recently, probably the one that I'm most proud of with this institution is really partnering with Xavier, one of our amazing historically black colleges and universities here in New Orleans, amazing allied health program, and we're opening up a new medical school here in New Orleans in conjunction with Xavier, so that hopefully we can start to really train up some folks from New Orleans to take care of people from New Orleans, and I think that will be very important. Oh, and then within that booklet too, I wanted to put this picture up there. I was looking through it yesterday, and this picture popped up of Mark Matrena, and I just thought I wanted to put it in there because he's also just the most trustworthy face in medicine. So, all right, what are some more concrete things that we can do right now, though? I think one of the first things that you can do is if you're involved in a radioligand program is really making sure that you're removing any kind of implicit bias into who you're referring into the program. If you're really just saying, I'm just going to take patients that show up in my clinic or whatever like that, you're going to miss a whole lot of patients. And so if you think about ways that you can develop real reporting benchmarks, through whatever kind of EHR that you use, to make sure that you're seeing where patients are, that maybe the ones that you're not seeing. Where are you missing those patients, and how can you go out and reach them to get them shuttled into the healthcare center? So Novartis, fortunately, I guess they put out this Pluvicto Epic toolkit for those of us who are unfortunate enough to work with Epic, or fortunate enough. You can utilize this, I kid, I actually really like Epic. But you can utilize this worksheet. It kind of works, it walks you through like step by step of how to make a reporting benchmark to identify patients within your health system that could be eligible for the drug. If you're not with an Epic, there's other third-party vendors that you could potentially use for this. And then also making sure that you're maintaining good communication with your referring partners from outside your institution, making things visible for them to know where they stand in the referral pathway. And then finally, the last thing, and probably the most difficult thing that we need to do, is really just expand out more radioligand centers. This map, I'm kind of focused more on how things are looking in the United States, but I think this map really kind of highlights how this is going to be a global issue for supply across the entire world. It looks at per capita use of radioligand therapy for prostate cancer. If you look at it, obviously Australia and Germany have traditionally been at the vanguard of radioligand therapy treatment, so not surprising that they have very good per capita numbers. But in the United States, we're in yellow. That's not great. And I think I previously showed you earlier the map of where the PSMA, PSMA PET sites were. If you did a similar map of where PSMA radioligand treatment centers were, it would probably look very similar. So we talked a little bit about the barriers of how you can put together a radioligand program, but this was from a review of how we can, what other sorts of barriers might be there in developing radioligand programs. So if you think about this, we talked a little bit about inadequate physical structure. Really making sure that we can invest, particularly in certain healthcare systems, to build out these sorts of programs. That we have the professional capacity to really have those authorized users. What can we do to make sure that we have an adequate supply of nuclear medicine physicians and radiation oncologists? Unclear models of care, this is something that comes up when you refer somebody in to get a radioligand treatment. Like, who's the quarterback in that situation? Is it the medical oncologist from the outside institution? Is it somebody from within the institution? Is it the, is it the nuclear medicine doctor? Making sure that your center has very clear, defined pathways as to who's taking care of these patients and who's responsible for what. Low awareness and understanding, hopefully that's something that we're helping to take care of here today by increasing awareness for these sorts of treatments. And of course, the legislative regulation and reimbursement policies are things that we need to think about. So if we think about, the potential solutions that we could put into this, I kind of think of it as a different type of multidisciplinary team, not the traditional one that we think about, but really thinking about our partners from the governmental side of things, our partners from the industry side of things, and then finally our role here within the healthcare system side of things. So from the governmental side, we really need to make sure that we're finding policies that incentivize, capital investment into radioligand programs, particularly for, maybe smaller, or more rural or, types of settings. We also need to make sure that we're harmonizing, education and training standards kind of across the board so that we all know, what goes into getting this sort of training programs, and getting clear and consistent regulatory frameworks so that we can speed along the regulatory burden involved in opening up these programs. For industry, making sure that we have a diverse supply of these treatments. It's not just industry. Making sure that we have a supply of rare earth metals is going to be important too, so that's on the governmental side of things. And then also continuing to invest in real-world data to see how we're using these drugs and how cost-effective they can be. And then finally, from the healthcare system, making sure that we are telling our colleagues and our patients about these new drugs and increasing awareness throughout the community. Making sure that we are training up enough of these nuclear medicine specialists, developing clear patient pathways and standardized clinics that take care of this, and finally sharing best practices. So, in summary, radiopharmaceuticals are growing. They're not going away. We're going to see more and more of them. As Dr. Sartor said, we're going to see more and more indications over the next several years. And we already know that significant disparities exist. So if we don't intentionally think about how we expand our programs, we're only going to exacerbate those disparities. And finally, we need to identify those barriers, but really put together that multidisciplinary team of working with our legislators, working with our health administrators, working with our pharma partners, and really making sure that we expand these treatments to all patients who would benefit. With that, I also got some pictures from Mardi Gras this year. That was all the way on the right is what it looks like right before a float rolls. So I threw all of that onto St. Charles Avenue. So thank you guys. We'll get another chair. Is this working? Okay, that seems like it was working better.
Yeah. Thank you to our speakers. That was a very thought-provoking session. Dr. Halbert, I want to thank you for bringing up that topic. I will add, cancer statistics are not going to change unless we, apply treatments to all people. It's mathematically improbable that we will make any impact unless we apply it to everyone. So thank you for bringing that to attention. So I wanted to open the floor up to any questions that anyone may have right now for any of our speakers. Anyone? All right, well, I'll start. Dr. Sartor, how do you, with the rising use of radioligands, I guess the big million-dollar question is sequencing. So, where do you kind of fit in lutetium in someone who, for example, has a BRCA mutation, and how do you fit that in with the PARP inhibitor before, after, during, or?
Actually, the PARP inhibitors are incredibly active with BRCA1, BRCA2, and I typically give the PARP inhibitor first. We don't have a lot of data with radioligands after PARP inhibitors. It's conceivable that you could put the two together, but there's really not much in the way of data to support that. And would worry potentially about toxicity. I did present the phase 1 data from Janine Sandhu. I've actually done combination therapy, and those with a somatic BRCA2 mutation had a beautiful response, by the way. But I think in general, for those with a BRCA mutation, probably the PARP inhibitor first is the better way to go.
Okay. Where do you think chemo kind of fits into that picture?
Yeah, really important question. So we have two studies that directly compare chemo with radioligand. One was presented at ESMO in 2025. The other was presented as a therapy trial out of Australia. In both cases, there was no improvement of the radioligand therapy relative to either docetaxel or cabazitaxel. And there's still some question in my mind over the tolerability of the docetaxel or cabazitaxel after the lutetium has been given. If you have a patient with a high volume disease, I think it's reasonable to go with the chemotherapy first. If you have a patient with a low volume disease, and there's data to show the low volume disease has less marrow toxicity with the radioligands, I think going with the lower volume disease with radioligands is very reasonable. Please remember that oligometastatic disease can be radiated. You don't need to bring a systemic therapy like a radioligand into that situation, although it can be considered. Anyway, there's a little bit of nuance depending on the age, comorbidities of the patient, depending on chemotherapy, volume of the patient. When I say volume, I mean disease volume of the patient, all fit in. There's one interesting study that I think is relevant. Now, do look at this. Circulating tumor DNA allelic mutant fraction, when it's extremely high, the patients do not do well with lutetium. They do better with a lower mutant allelic fraction. You can measure that on a Guardant or a Caris type assay, circulating tumor DNA. As we go forward, I think we're going to have better biomarkers to help us choose, but right now we're still in evolution.
Okay. And last question to you from me, but where does radium still fit in? Is it relevant anymore?
Yeah, radium's pretty rare in our armamentarium today. I did actually use radium recently in a guy who had PSMA PET positive bone metastatic lesions only, were quite osteoblastic. One of the things that we do have data on is lutetium post-radium retains its activity. And so in this particular case, I did use radium first, and now I'm switching over to lutetium second, as he develops some soft tissue disease. Radium also has a pretty good track record for being given before the chemotherapy. So chemotherapy post-radium, pretty good safety record. I mean, we have the approval going all the way back to 2013. So we have 12 years, 13 years almost of FDA approval there. So radium does not have much of a role today, but I occasionally still use it. PSMA PET selected bone positive patients only. If they have soft tissue disease, probably no radium.
Great. Any other questions from the audience?
You were mentioning around like the third dose of Pluvicto, watching the PSA decline to say if it's working or not. Are you looking for a certain percentage decrease? And just to know when to stop treatment if it's not effective and then apply toxicity.
Yeah, great question. And you know, I think we still are struggling a little bit with this. The patient has had a clear PSA increase, and by that I mean 25% above baseline or more. I'm really thinking about other therapies. If the patient is stable, then always look at the clinical parameters, because you know we often have pain, appetite, fatigue to be able to assess. It's not just what the scans and PSA shows, what the patient shows. Patients who are clinically benefiting, I tend to continue. But if there's substantial increase in PSA at 12 weeks, I'm thinking about other therapies.
I'll follow that up with a question. When do you know to stop? If they have a really good, PSA 90 response, do you repeat a PSMA PET scan to see, after 2 cycles to see if they still have PSMA, have a disease?
Yeah, another really good question. And we've struggled a little bit in answering it because of the lack of prospective data. I'll simply say that I've begun to get the PET scans, particularly when we have a good response. What I'm really looking for is oligometastatic disease that I can then convert to an SBRT-treated patient, as opposed to necessarily giving more of lutetium right then. With the adaptive therapy, and Louise Im is the master of this in Australia, Sydney, Australia, if she's got a really good PSA response, she'll just give 2 and stop. And then you can repeat it later. The repeat responses to lutetium in those who responded initially is extremely high, probably in the 80-90% range. So adaptive dosing is something we're still working through, but consider that PET scan to choose the patient to verify the response. I mentioned the paper in Press from Louise, I'm a middle author, Louise is first author, on the PSMA PET total tumor volume being a really important prognostic parameter. Thinking about oligomets, thinking about SBRT, thinking about adaptive therapy, about holding therapy and then re-administering, you have more disease. All of these are in the works, and it's an art form today, and I'm not sure that I have the art form perfected, but we're all going to work at it.
So I have a kind of a broad question. Post-Pluvicto, you don't have any next-generation areas, so you don't have oligometastatic disease, but you have rejected disease, particularly if you have some cytopenias, which occurs in post-Pluvicto. What's left? Because that's where I find myself too often.
Yeah, really good question. It depends on whether or not it's a pre or post-taxane situation. Taxanes are clearly active in the post-Pluvicto setting. The question is one of tolerability and immunosuppression. One of the trials that I really liked that was published, over 10 years ago now, was using the 2-week schedule of the taxane, the 50 milligrams per meter squared Q2. Author named Kelcom Kulatinen out of a Lancet Oncology 2013 article really showed the 50 milligrams per meter squared Q2 actually beats 75 milligrams Q3 head-to-head. So overall survival was better in that trial's secondary endpoint. A lot of people don't realize that. I use a lot of the 50 milligrams per meter squared Q2 taxane for docetaxel. That gets you into a better position. There's also a French study looking at cabazitaxel Q2 week dosing. Trying to remember, I think it might have been 15 or 16 milligrams per meter squared of cabazitaxel Q2, and that also came out better. So reduce the intensity of your taxane, and you might be able to do a little better. Our clinical trial.
Any other questions?
So, with PSMA PET scans developing and different tracers and everything, where does that leave conventional imaging? Like, what's its role with conventional imaging now?
Yeah, it's a great question. I mean, currently in terms of approvals and insurance approval too, it factors in where currently, at time of diagnosis and biochemical recurrence, but technically all the studies that we're citing and restaging over the last 5+ years has been conventional imaging based. There's now different guidelines, working group guidelines that incorporate PSMA PET in restaging. But the other aspect of that is also, as Dr. Sartor mentioned in his talk, PSMA expression is heterogeneous, and particularly, post-Pluvicto, is PSMA PET, the best imaging modality? Probably not. There are other tracers under development, as you mentioned, but conventional imaging, I think, still has a place. But in terms of, what you use for restaging, what you use at initial, what you use post-Pluvicto, it's kind of all over the place right now because we don't have any, study data kind of guiding that decision. But
one other brief comment. The liver is problematic. As you go further into the disease, you end up with a higher probability of liver metastasis. And a lot of these are not PSMA PET positive. So conventional imaging, I think, is really important for the liver. And it's not just the CAT scans, the CAT scan with contrast and the one with contrast to be able to see these lesions. Some of them can be quite subtle. And the other thing we haven't talked about is neuroendocrine differentiation or the double negatives. PSMA PET positive is only one classification disease. There are others. And it's a lot of MD Anderson work on the so-called, what's the term? Aggressive variant, and where the use of platinum plays a role. And problem with that we have to worry about post-Pluvicto, platelets, because the platelets are vulnerable in that post-Pluvicto platinum-treated patient. So we're still learning, and we have a lot of unmet needs. I'm a little bit enthusiastic, although not in the visceral disease, on these T-cell engagers. Both the STEAP1 and the KLK2 are both clearly nice in terms of their response rate. Phase 3 trials with the COMPASS trial that you're familiar with, also a new one, pasritamig, coming in with docetaxel. STEAP1 will essentially complete accrual in the next 1 to 2 months for the phase 3 from Amgen, and it's likely to be a positive trial.
Anyone else?
Dr. Sartor, when you talk about alpha particles being better suited for smaller cell versus beta with the larger group cell, so when we're looking at these alphas that are in the pipeline, is it fair to say that alphas will be better suited then for earlier disease with that smaller cell, and then the betas, because they're traveling further and the LET is a little bit different, it will be later disease?
We're still working through it. When I showed you the LUNAR trial, which Jeremy Clay presented out of UCLA and others at UCLA, the ability to treat the microscopic disease with SBRT plus or minus lutetium was actually pretty impressive. It has ratios 0.37. That's like real data, although with PSMA PET as progression criteria, not FDA approvable. As we go forward, I think some of this gets a bit complicated. Actinium actually has 4 alphas. It's not just a single alpha. It might be that some of these single alphas, like the lead-212, could be better in early stage, a little easier on the marrow, a little bit easier on the kidney. We're going to have to run the trials. The alphas are probably better, but they also bring more toxicity and more salivary tox. The 617, which is Pluvicto, with actinium on it, it's got some real salivary tox. So xerostomia is something we have to be concerned about. It's an evolving field. And by the way, we're working on it literally every day.
How are you managing these xerostomia? I think in the PSMA edition, it was pretty high rates of clinically significant xerostomia for these patients. It bothers them, and that's something that I worry about when we think about moving Pluvicto, further and further up.
Yeah, great question. And there's a clinical trial about to get underway, prospective trial with Novartis. Today, hydration is the simple one. Harder candies, particularly sugar-free candies, you can just kind of suck on and kind of lubricate, and lemon drops and stuff like that. They can make a difference. Xylitol, I don't know if you've used xylitol at all. It comes in either gums or lozenges or even a little pack. Can help, and xylitol is actually cheap and easy. There are things like pilocarpine that can actually stimulate, and there's a head and neck literature around xerostomia because of the external beam radiation xerostomia that you can play to. There also, and this is part of a clinical trial, is to look at a device that is actually almost like a retainer from the orthodontist that will slowly leak a salivary substitute. And so it's kind of a constant lubrication. There's a little French company that's working on that, and they're teaming up with Novartis to be able to do a trial to look and see whether or not that really does. There's preliminary data that that's a good way to treat it, but it'd be like a device you have to get fitted. you have to go to like the dentist, or maybe they're trying to do like an AI thing where it'll fit and then come into the palate and then sort of leak this fluid on a continual basis. But it can be a tough problem, and it can really be problematic with the alphas. The actinium is a salivary gland destroyer. By the way, they're also looking at salivary tumors and the use of PSMA targeted therapy at Johns Hopkins. And that's, you get that salivary uptake. So if you kill salivaries, maybe you can kill salivary tumors too. So positive side to it.
I have a question for Dr. Pillay. A lot of what you mentioned about the Poseidon data, the decision to give ADT and how long is dependent upon risk. But do you find like a lot of these high-risk patients are getting surgery, and should a patient with a Gleason 8 get a radical prostatectomy, theoretically?
Yeah, and that's a topic that every urologist and radiation oncologist will forever debate. But I think it's hard to ignore, Stampede and other data that in the high-risk setting, there is biological outcome differences when we combine, anti-androgen therapy and radiation therapy. All of our, to date, neoadjuvant studies with surgery and anti-androgen therapy, adjuvant studies have not shown, additional benefit to the combination. So just purely out of, we're never going to have a direct comparison trial to go off of, but just in the last 5 years, what has significantly improved outcomes for patients with high-risk localized disease has been the medical oncologist with the systemic therapy addition to radiation therapy. So I think, more and more that needs to be highly considered, and obviously, the patient's active participation in that decision of upfront surgery versus radiation, and quality of life issues and side effect issues, and all of that needs to factor in. But purely based on the numbers, I think we should start questioning more and more, surgery versus upfront radiation in these higher and certainly very high risk N1 positive patients.
One of the downsides of the radiation is it does require that systemic therapy, which a lot of patients are very eager to avoid. And so when you're giving radiation high risk, you pretty much have to give the hormonal therapies with it. And the abiraterone Stampede study, clearly positive study. We are at times committing people to 2 years of therapy with a hormonal agent, and that is not attractive to a lot of men either. So as we think about these non-castrating therapies, and I mentioned the T-cell engagers, several times already, I mentioned the radioligands, of course, many times. I think the radioligands and the T-cell engagers may play a larger role as we go forward, but this is going to take a long time to study properly because the outcomes don't occur within 3 years or 4 years. The best outcomes are 6, 7, and 8 years. So the study is going to have to go on for a long time to be definitive.
I think the next phase of de-escalation studies, as was touched on in all of the talks, are going to be kind of the current, because, as was mentioned, men don't want long-term castration. So all of these new agents, the RIPTAC and radioligands and T-cell engagers, moving up earlier to spare castration.
Great. Okay.
It's a question for each of you. I think Dr. Halbert's talk and honing in on the disparity. I'm just curious with medical oncology and these patients with urology, what do you see in each of your sites as far as when everybody is appropriate and how y'all are working together to manage these patients?
Yeah, I mean, I think it's been a long-standing issue to look at getting patients into medical oncology, so that at least so that they're getting, appropriate upstream care from their castrate-sensitive disease. I think we all work in different disease states. Fortunately, we have good relationships with our urologists who are very happy to refer into us pretty early. So I think within the Ochsner community, we're pretty good about capturing our patients within. I think where we may be losing some leakage might be, with patients that may not be followed within a large integrated health system, but might be still being treated by, a smaller practice or, one of the larger practices out in the community, but that aren't necessarily integrated within medical oncology clinics. So we need to do a better job of integrating with those, with the LUGPAs and with, single practitioner urology groups and making sure that we really seamlessly get better, referral practices in, and so that they also don't feel like they're losing their patients, because, I think a lot of times they don't like to bring patients in if you feel like they're just, they're going to lose that relationship, and if they're going to, lose that time that they get with their patients. So making sure that, you work with the urologist to, kind of see what level they want to stay involved with.
I think Dr. Matrana's talk at a roundtable at 2 o'clock kind of addresses this issue: is who ultimately is guiding prostate cancer treatment for patients. Is it the urologist or the medical oncologist? And as Dr. Halbert says, that varies by location a lot. So.
I mean, that's kind of part of what we were saying earlier with one of the barriers of expansion of radioligand therapy is this, unclear models of care. It is. It's like, who is the quarterback for these patients whenever, they might have been followed with their urologist for 10 years and then they've been seeing you for 5 years and now they're getting nuclear medicine, it's getting involved, and, really making sure that each institution comes up with something that works for them and their patients, but just so that we all know who's doing what.
Short answer is all the, everybody has a role to play. There are things that urology does that I'll never do, things that radiation oncology does I'll never do. It does take a village in order to be able to do it optimally. The village is most functional when people are all communicating with one another, and that's the optimal setup, is to make sure the communication across specialties is clean, referrals happen rapidly or even in real time. And that's a huge advantage to the patient. If you're just isolated and have only one specialty, I hate to say it, you're probably not getting the best of care throughout the continuum of prostate cancer. Sure, for surgery, it's going to be urology. For radiation, you must have. But at the same time, integrated therapies, including combinations that we use every day for the hormonal therapies, that's probably best an integrated approach.
Yeah, and I think in that space too, increasing roles for non-physician members of the team, patient navigators, coordinators, that can help sort of quarterback that overwhelming coordination aspect, for the patient, and understanding, who's part of your care team, who's responsible for what, and who do you need to see when.
All right. Any other questions? All right. Well, thank you all for joining us today for this wonderful session. Thank you to our presenters, and enjoy the rest of the conference.
got on your schedule,
Test,
okay?
test.
This is where we're at.
So we have that keynote first.
Yeah, it's going to be Dr. Mark Matrina. He also has a video to play.
I'm sure he knows how to use a computer.
Yeah. Well, I had told him first before this lady had asked. Yeah. That someone would be sitting over there and he would just look over and say, "All right, play the video now." So I just have to. Yeah. Now I'll just have to tell him. I couldn't download his either, so we'll just have to do the slide and Google Drive, which is not a big deal. But they kept giving me errors. Well, I don't even need that. I don't care because I got a slide. It doesn't matter. I was trying to download. I kept getting error messages. So what I need is the video, but I should have that open the downloads, the file export. And that's fine. If it works on PowerPoint, it works. Why does that work for you? All right. Thank you. And the video is not in there. Let me see. Check it. I should have downloaded already. So you have to go.
Gentlemen, do you mind if I interrupt for 7 seconds for a quick photo op?
Absolutely. Go ahead.
I'm gonna podium this.
There you go.
Yeah.
Get out the way.
You got it? Okay. Cool. Thanks, guys.
So I don't see it in here, so let me go back to Google Drive. This is his video. Yeah, I don't fucking care. Shit, we have to test it out too, because the sound. Wait. Dude, this better fucking work. It worked yesterday.
What, the video?
Yeah, this is gonna make me have an aneurysm, I swear to God. I mean, I guess he could just do that.
Yeah, I honestly feel like
The sound
Does this sound?
Maybe because it's not hooked up yet.
I think it's because it's just not plugged in.
Thank you.
You hear me? Alright, we'll test anyway. Do we have all the slides though?
Absolutely worst case for his, because the lady who wanted it doesn't come on till like 2 o'clock. So we have another break. Worst case, I could bring it back over there and you just do your thing and pull up the video.
So we're going 2, 2:30, 3, 3:30. These are all, and then what is this? Is this that keynote?
That's at 11. Oh, all right. So check this. So that's 11:50. That's your special announcement. Dr. Mark Matrana, that's him. He's gonna come up at 11:50. That's the guy who has the video. Okay. Then the keynote. She sent hers on PowerPoint. So that's on the PowerPoint right here. So is there a presenter view on this? I don't know how that works. Fuck. Do you know? Full screen mode. Okay, all right, no, that's good. I just want to make sure. So that's the keynote 1220. So the lady who wanted this on the podium.
So this guy
doesn't
needs
come
no
on.
PowerPoint. This is video, and this is keynotes on PowerPoint.
This is keynote. So this is Matrana. I could get rid of this since you downloaded it. We just did it. So that's 11:50. That's your special announcement, and then he's gonna get to this page with the AstraZeneca logo, and then he's gonna say something about video. Are you good to go? It worked yesterday, but we got to test it before.
Yes.
I'll bring it back later.
If everybody could grab a seat, we're going to start with our next keynote speaker in just a minute. If everybody could grab a seat. We still have some open seats over here to the right of me. We want to take advantage of every open seat. If you don't get a seat, as Dr. Matrana mentioned, there's an overflow room right next door where they're live streaming all this talk, this general session. If we could close the exit room door, the door, please. Patrick, if you could close the door for me over there. Thank you. Dr. Janasia, you can come sit up here with us. All right. You ready, Dr. Matrana? If everybody could please grab a seat. We still have almost a whole table over here open if you guys want to grab a seat. Jake, can we close that door? Okay. Okay. All right, here we go.
All right. It is so gratifying to see such a big crowd here of people who are so passionate about cancer and finding a solution for it. So before we have our keynote speaker, we wanted to take a few minutes for an announcement. And this is something that we alluded to at our last conference, but we have a lot more information to share with you. And so you may have heard of our Louisiana Cancer Endowment, and I like the way that Chad had described it earlier. So CAGLA is really a two-legged stool, right? We have the advocacy work we do in Baton Rouge to pass new laws, and we have the educational part of the stool, the leg of the stool, which is what you're at right now, the big conference and other educational opportunities. And the Louisiana Cancer Endowment is our third leg. This is our research leg. This is a separate entity, legally a separate entity, a nonprofit that is geared towards cancer research. And we're going to talk about this in a little bit more detail. So and I think I'm preaching to the choir, because I think you guys probably know this than just about anybody, because you see it every day. Cancer in Louisiana is a national crisis. There's no other way of putting it. It is a crisis. Why? Let's see if there we go. We have the third highest incidence rate of cancer in the country. We have the fifth highest mortality rate of cancer in the country. And if you live in Cancer Alley, anywhere between Baton Rouge and New Orleans, you have a 95% higher chance of getting cancer than if you lived anywhere else in the country. In addition to that, our disparities are the worst in the entire developed world, meaning people who have access and who don't have access to treatment. Here's Cancer Alley. This is the epicenter of cancer in the United States, right here, Baton Rouge to New Orleans, the river corridor. Let's see, my slides are moving slow. There we go. And so, we formed CAGLA 7 years ago, 8 years ago now, to do something about this, to change the trajectory. And you know what? We've made an impact. And, had we not done anything, we would have been exactly where we were 7 years ago. But we did something. And as Chad mentioned to you before, we formed this coalition of cancer physicians, cancer survivors, and cancer philanthropists who show up every time we ask them. I mentioned earlier that every time I go to one of our scientific advisory board meetings at Copeland Tower, I drive there thinking, is anybody going to show up to this thing? And then within 30 minutes, the room is completely packed, and we've got 50 incredibly passionate physicians who are all ready with their ideas and ready to volunteer and lead committees and help us in any way they can. It's amazing. We're led by one of the hardest working board of trustees anywhere. And of course, this is our group. You've probably seen these faces around today. They're doing all the heavy lifting of preparing the conference, and nobody does any more heavy lifting than Chad. So he is, I don't know how he does it. I don't know how he does it. So he has a pool of energy that just is never exhausted, yeah, which is phenomenal. And this is our scientific advisory board. I hope I didn't forget anybody because it's ever expanding. But these physicians represent every medical specialty that touches cancer. They represent every corner of our state, and they represent every major health system in our state as well. From Our Lady of the Lake to Mary Bird to Willis Knighton up in North Louisiana, to LSU Shreveport, to UMC in New Orleans, to Truro, Tulane, East Jeff, Ochsner, and the list goes on and on and on. Say Tammany and others, as you can see here. This is an incredible coalition. I've been around for a long time working in medicine in the state of Louisiana, and I've seen time and time again when some of these systems have tried to work together, and when you do it from a top down, it generally doesn't work so well. We've done it from a grassroots. We're starting with the people who take care of the patients every day and going from there, and that has worked, because we all have one goal in mind, is that's to improve the lives of cancer patients in our community. So as I mentioned, CAGLA, two-legged stool, advocacy. We've passed 15 bills into law in the last 5 years. We have a 100% success rate. There is virtually no advocacy group in the country who can claim that. Not one bill that we have brought to the state capitol has not been signed by the governor into law. And of course, education. This is our biggest conference yet, our 5th annual conference. I think we have about just under 1,500 people here. It just grows every year. It's our 3rd venue because we've grown out of the others. And we had to hold our registrations because the fire marshal actually got onto us with this space. So we may have to even look for bigger space in the future. We'll see. But that 3rd leg is the Louisiana Cancer Endowment. Why did we do a cancer endowment, and what is a cancer endowment? If you look at ASCO, ASCO has the Conquer Cancer Foundation. This is a foundation that gives research grants. This is a nonprofit that's associated and affiliated with ASCO. Let's look to the state of Texas. The state of Texas basically has their own NCI. It's called a CPRIT. They have $6 billion that sits in a fund and generates income every year, generates interest, and they use that money to give research dollars to physicians and researchers in the state of Texas. So they don't have to compete for federal funds like other states. And lots of states have this. In Louisiana, prior to LCE, we had exactly $0 set aside for this. But we're changing all that. So we're, as I mentioned, inspired by Texas, inspired by Washington State's Andy Hill Care Fund, and others. If the state's not going to do it, if nobody else is going to do it, we've got to do it. We've got to do it ourselves. And so the physicians, the philanthropists, and the survivors of CAGLA got together and formed this organization. So what will this do exactly? As I mentioned, research grants, seed funding, travel awards for fellows, education, so on and so forth. So what we did is we took some of our senior leaders from CAGLA and we decided to make them part of our leadership for Louisiana Cancer Endowment. So Chad is the chairman, I'm the executive director, Al is our development officer and director, and Karen Stahl is our secretary and director as well. We also took a component of our scientific advisory board, and these are our peer reviewers. No funds will be doled out through the Louisiana Cancer Endowment without a very specific peer review process. This will all be anonymous and so on and so forth. And, we want to talk a little bit about opportunities and partnership, because we can't do this alone. There's no way we can do this alone. So we had some initial donors, which we appreciate very much. Tempus, the Karen Stahl Breast Cancer Research Institute, the Maudie Cancer Fund, and Kim Grow and the Breast Cancer Recovery Fund all gave us some startup funds to get this off the ground. And then we also have 2 founding gold partners, which we would like to recognize today, and that is Pfizer and AstraZeneca. And what I can tell you is that because of the partnership that we have, and we'll go into it in a few moments, but because of the partnership that we have engendered with this group, with these 2 groups, they have a huge advantage in the market now in the state of Louisiana. They have access that they've never had before. We're doing projects, and in fact, I'll announce now after our keynote speaker at 2 o'clock, it's a closed-door session with Pfizer for any physician or APP who's here that treats prostate cancer. We'd like you to consider coming over to Track 4, it'll be a closed session, and we're going to look at some very critical and very sensitive data around treatment patterns of prostate cancer in the state of Louisiana, and we're going to brainstorm on how we can improve these. And so this is the type of work that we're doing together. So first, I'd like to recognize Pfizer. Pfizer has pledged $100,000 initially, with an option of renewing that every year for up to 5 years for a $500,000 pledge. And so I'd like to recognize Pfizer and bring all of the Pfizer folks from who are out here up to the stage. Thank you all. Thank you all. You want to say a few words?
Yeah.
Okay. I'll do a picture of everybody.
That's right. All right. While everybody's getting on stage, I'm Michael Artman with Pfizer Oncology. I just wanted to say on behalf of my team and also our team at Pfizer Oncology, a sincere thank you to CAGLA and also LCE for their collaboration and also making this partnership come to fruition. We were very honored. We also are very excited to help cancer patients throughout the state of Louisiana, especially in Cancer Alley, which is our huge focus. So again, thanks again for all the hard work we put into this, and looking forward to some great success from this project. Thank you very much.
Let's see if we can get together for a photo. Okay. Let's see it. How can we do it? I don't want to. Oh yeah, we're here. Okay, maybe we can do it. Why don't we do it after? Want to do it after?
Sure.
Okay, we'll do it after. Okay, yeah. Okay, great. So we really appreciate the support from Pfizer. Now, our next sponsor, our next founding partner, is AstraZeneca. And AstraZeneca pledged $500,000 as well. They gave us $300,000 up front and plan to give $50,000 each year for the next 4 years. And so with these 2 pledges, we have raised over $1 million for the Louisiana Cancer Endowment in our first year. And so I really appreciate having 2 folks from AstraZeneca here today, because they are having their national sales meeting out in San Diego. Is it San Diego? And everyone from the entire company is out there. Some of them are coming in tomorrow. They couldn't be here today. But Jim and LJ, who have been an incredible partners and really made this happen, were able to come, and I'd like for them to say a few words as well.
Well, I will say that the local people stayed back, and I'm a local person from Ponchatoula, Louisiana. So I'm glad to be here. AstraZeneca is all in with the Louisiana Cancer Endowment. It's been a pleasure to work maybe over the last 18 months with Chadwick and Dr. Matrana to really shepherd this through internal logistics at AstraZeneca. And as Dr. Matrana just said, our entire company for oncology is at a meeting right now, and Mohit Monreo, our Senior Vice President for Oncology for AstraZeneca, has pre-recorded a message, so thank you. Thank you.
Oh, yeah. Oh, wait, we can get it in front of us. Oh, good. Thank you. All right, we can go ahead and play that video.
you for this special recognition. On behalf of AstraZeneca, we are honored to be a founding partner of the Louisiana Cancer Endowment. We have a shared mission to eliminate cancer as a cause of death. We are helping ensure sustained investment that pushes oncology research forward, expands access, and improves outcomes for every patient, especially in communities that have carried a disproportionate burden for far too long. Partnership is how we all will make progress. Together with LCE's physicians, survivors, and advocates, we will help accelerate early detection, advance clinical research in Louisiana, and strengthen equity across the state. We are truly grateful to stand with you and CAGLA at this year's 5th annual conference, and we are committed to turning today's momentum into action that translates to progress. Thank you so much.
Yeah, thank you. Thank you to AstraZeneca. We really appreciate it. We really appreciate it. All right, we can go back to the slides now. So we are so appreciative of Pfizer and AstraZeneca, and as stated, they're bringing great value to the state of Louisiana, but our physicians and our cancer providers at every level are also bringing great value to these companies because we're doing projects together. We're being kind of used as a sounding board, as a brain trust, and we're really looking forward to what the future holds. There's still room. There's still room for additional partnerships, and we want additional founding partners. We won't have that opportunity open for long, but we do want to open it and extend it. And we hope really that every one of our sponsors, every one of our companies who are here today can work with us in some way to make this dream of a cancer endowment for the state of Louisiana a reality. And we hope that those of you out there from these companies who can bring this up your chain of command will do so. And so here are some of we can work with any company in any way that you see fit, but this is our initial framework. Bronze sponsorship, which would get you recognized as a partner. Attending dinners with our folks would be a $25K annual ask. A silver partnership, which would allow your company to speak at these events, would be a $50K ask. And then for gold, which is what Pfizer and AstraZeneca are, at $100K annually. This is really the full package. So you can do special projects with our teams. We can really make this work in any way that you see fit. But this is really where you get the most value, and this is the $100K annually membership. We also have a platinum membership at a one-time gift of $1 million. So please bring this up the chain of command. Let this be known to your companies and to your executives. We really appreciate it. You can contact Chad or I to discuss this at any time, and we'll definitely be circling around. I know some of the companies already are working with us to make this a reality, so that next year we just don't have 2 companies to announce, but we have a whole slew of companies to announce as LC partners. So thank you very much, and with that, we're going to change gears a little bit. So heard about LCE? You know all about it now. Hopefully it's going to roll off your tongue just like CAGLA does, LCE. You know exactly what it is. But we're going to shift gears now a little bit, and I'm thrilled to welcome our next keynote speaker, Kathy Gusti. And I know some of you were present for the award ceremony last night at our reception, where Kathy won our National Advocacy Award, the CAGLA National Advocacy Award. But for those of you who weren't there or may not have heard, I just want to tell you a little bit about Kathy. So I first met Kathy at Harvard Business School when I was, and some of my colleagues were taking the How to Start a Precision Medicine program at Harvard Business School in Boston. And Kathy actually was a co-founder and one of the leaders of the Kraft Precision Medicine Accelerator at Harvard Business School for a number of years. But that's just one of the hats Kathy's worn over the years. Kathy is a nurse with a heart of gold who was diagnosed with cancer not once, but twice, both multiple myeloma and breast cancer, so double survivor. And as I mentioned last night, when most people get a diagnosis of multiple myeloma, they might go home in despair and, wonder what to do next. Kathy went home and raised $100 million. So, just $100 million, right? And she started the Multiple Myeloma Research Foundation, and she'll discuss this, but which has done more for multiple myeloma patients than just about any other entity on the planet. One of the things that they've done is started the Cure Cloud, which is a massive database of genomic information that's fueling all sorts of innovations in the multiple myeloma space. And so Kathy served as the CEO and president of the Multiple Myeloma Research Foundation really for decades, and drove that foundation to what it is today, which is a major international foundation that's having a massive impact. And she's been recognized for her work. In fact, she's been named one of Time Magazine's 100 most influential people, which is amazing. And if that wasn't impressive enough, Forbes magazine named her one of the 50 greatest world leaders, period. 50 greatest world leaders. So to have someone of Kathy's stature and her, and by the way, she's also an author who just came out with a new book too. So hopefully she'll tell us about that as well. But to have someone of Kathy's stature and international reputation, and honestly her passion and her heart to be able to speak to us today at CAGLA here in New Orleans is an absolute honor, and I'm so happy to welcome Kathy to the stage.
Thank you so much, Mark, and thank you, Chad, for inviting me. I'm really excited to be here. Excited because I feel like myeloma is now the case study in how to move cancer forward and how to find just unbelievable progress. This is actually the first time I'm presenting this title, which is called A Cure in My Lifetime. I never, ever dreamed that I would be saying that, and let me explain why. I was diagnosed with multiple myeloma at the age of 37. That was 30 years ago, and a long time, but many of you that are older in this room will remember at that point in time, it was a really tough disease. In that picture, I was in the peak of my career in the pharmaceutical industry. I'd been at Merck and then Searle, which became Pfizer. We just bought a new home, happily married, and our little girl, Nicole, was 18 months old. And my husband and I, honestly, were putting up our Christmas tree. I remember this still so many years ago, and looking at each other and saying, oh my God, we finally made it. Like, we've paid off all of our student loans. We're doing this. Like, this is amazing. And then, of course, life does change in an instant. Because following up on a physical, just a regular physical, to get referred to a fertility doctor for our second child, they found interesting things in my blood, which was the anemia, high protein, and all of that led to more and more testing, and then my formal diagnosis of multiple myeloma. Back then, multiple myeloma was a 100% death sentence. Patients lived 3 years at best. The 5-year survival was actually less than 30%. The drugs I was being offered were the same drugs that had been offered to my grandfather when he had multiple myeloma, and nothing was going on in this disease. Now, we all wonder, like, if you're facing a death sentence for the first time in your life, what goes through your mind? And I can tell you what went through mine. It became my North Star, which was, if I could just live longer than the 3 years, maybe, just maybe, our daughter Nicole would remember me. And in an effort to have her remember me, I left Borders Bookstore, where I had been researching Merck and Harrison's and everything, trying to understand my disease, because there was no internet back then. And I grabbed a journal on the way out, thinking, I'm just going to start writing to her. Like, I'll just document the things that we do for the next 2.5 years and hope she'll remember me. And as I was writing in the journal, I found myself in the first 5 pages just like apologizing. I was so unbelievably sad. When you face death, you're not scared of it, you're just sad at all you're gonna miss. And so I was writing to her saying, I'll never get you a brother or sister. I have a twin sister. I always wanted a sidekick by my side. I'll never know where you're gonna go to school. I'll never know who you're gonna marry. And of course, all of it was crushing. But if I was going to live longer than the 3 years, I knew I had to do something pretty dramatic. I wasn't sure what, but it came to me when all of my teammates at Searle decided that they were going to do a fundraiser. I was working in new products and running worldwide operations there. I knew every agency, every employee, and all of a sudden, we were putting together a lot of money, and thank God my sister's an attorney and started a community fund for me, which then became a 501c, the MMRF. Now, the beauty of my taking on the MMRF as a very reluctant entrepreneur because, again, I was dying. The last thing I really wanted to do was start a company, was the fact that my background was in science, it was in pharma, and probably the most important part, I'd never run a nonprofit. We started the MMRF with just the skills I knew, which was how to run a for-profit Fortune 100, 500 company. And that's probably one of the best reasons why the MMRF was so successful. As a business person who had gone to Harvard Business School and had worked writing every strategic plan in the pharmaceutical industry, I started looking at myeloma and thinking, I'm not sure this is just a science problem. I think it's more of a science and a business problem together. And I started looking at the different areas that I thought would be most important for us to focus on. Now remember, back then, again, this is a long time ago, everybody was doing a lot of work more on the support group side and the hand-holding side. So to move in the direction of saying, nope, I think we'll start a research foundation, there were only 3 of us out there. And it was cystic fibrosis, ourselves, and Michael J. Fox. And the beauty of it was we all became friends and started sharing our ideas across each other. Bob Bell from Cystic Fibrosis, for example, sat on our board. And so I started walking through and saying, almost sequentially, I have to look at the talent that we have to look at the biology, the disease, trials, data, and how are we possibly going to raise all the money we need. So let's walk through how we came to understand this from a patient's perspective, who then worked with the scientists, clinicians, nurses, all the people in the room here today to identify business models that would actually have the incentives to drive multiple myeloma forward. Way back when I was getting a second opinion, I realized there were only 4 or 5 centers working in the entire field of multiple myeloma. It was the Mayo, Dana-Farber, Princess Margaret, Moffitt, Arkansas. And I thought, this is not going to work. If you want to live longer than 3 years and you only have 4 centers or 5 centers working in disease, we need a lot more scientists to support us. And of course, scientists have to move where the money is. They have to. They need the grant funding. They can't go there without it. So that became the most important part for us, and I'm seeing it now with CAGLA too. You've got to raise the money. And it's, by the way, the hardest part of the job. So we started, fortunately with us, my own annual appeal became my husband and my classmates at business school, and we were very lucky that we ended up with few $1-million donors out of that annual appeal. And that got us going out of the house, into the office, starting to hire our staff. Today, the MMRF has raised over $650 million for the myeloma community. The second part was understanding that tissue was actually the most important thing we could do as patients. I remember a Friday night as a patient being up at Dana-Farber, and all of a sudden, there were 2 scientists outside the door with a red igloo cooler. And I thought to myself, what are they doing? But they basically were headed up to the lab with my cells while they were still alive. And it made me realize that tissue is gold. Patient tissue is absolutely gold. So the first thing we had to do if we were going to support the scientists that were coming into the field was to get them a collaborative tissue bank, because you need critical mass in uncommon cancers. So to build that critical mass, we built a tissue bank at the Mayo Clinic, we paid the rent, we did the SOPs. We actually graded everybody on the quality of their bone marrows. And we actually put that out into the public for all of them to see how each other was doing. And then they helped us decide how would they use that tissue. But by this point, I was actually also on the National Cancer Advisory Board at the NCI. And sitting next to me was Eric Lander of the Broad Institute. And they were talking about the TCGA, which some of you will remember was the big genomic project funded by the NCI. And I thought, they're never going to get to multiple myeloma. So I reached out to Eric and I said, what will it take for you to sequence the myeloma genome? And this is just when genomics was starting. And he said, samples, expertise, and money. So we put together a grant. We had external review that was remarkable, and we became the first to sequence the myeloma genome through the MMRF. And that started helping our scientists to understand the basic biology of our disease. Then a patient found that angiogenesis and potentially thalidomide might be a game changer in myeloma. She actually asked Arkansas, Bart Barlegate, to put her husband on thalidomide, and he did. It didn't work for her husband, but the next patient went into a complete remission. So all of a sudden, there we are at the MMRF realizing we'd spent a lot of time at stem cell transplant, looking at vaccines, but now we had to move over to novel drugs. But we're nimble, and we're able to do that. But again, critical mass played a huge role. If we were going to conduct phase 1 and 2 trials of novel drugs, we needed our centers to work together. So we built a membership agreement that gave them all the bylaws by which they would do phase 1 and 2 trials with us. It was probably months and months in the making with all the attorneys at the academic centers for us to get this far, but then it was a take it or leave it. As we grew that consortium to 20, 30 centers, everybody had to sign off on the regular agreement. And today, the MMRF has conducted over 100 phase 1 and 2 trials with correlative studies across all of the cancer drugs. Then, as a patient, I'm an identical twin. I learned firsthand the importance of data. My identical twin and I actually raised our hands to go up to Dana-Farber, where she thoughtfully did bone marrow biopsies, and they studied the two of us. They looked at her immune system versus mine, our genomics, our epigenomics, everything that they possibly could. All of that data was published and made available for everybody to start to understand what were the targets in myeloma, what were we seeing with this disease. But when I brought the academic centers together, it got tricky because it's not that they didn't want to share data, it's just, it's administration. There's a lot of people you got to go through if you decide you want to share your data set across everybody else. As a result of that, the MMRF had to take on building its own data set. We had to invest $50 million of our own money, where we actually followed 1,000 patients doing all of their genomic sequencing, capturing all of their clinical data, CROs, everybody. It was a beautifully run study, and we did it for 5 to 10 years. The COMPASS data set actually became the most highly published data set in oncology. It's one of the most highly used. We put all of the data out in the public domain. In order to fund it, we developed a licensing agreement, because you had to be creative on how you raise your dollars. Certain people get the first look, but the whole world was always able to see the data. And today, the COMPASS study is still used because you can use the samples for immune profiling as well. And then, as we were writing the next strategic plan for the MMRF, we had done really well. Now we had Revlimid, Velcade, we were on triplet therapy. But we also saw the beauty of daratumumab from J&J, and we started to see the impact of immune therapy. At this point, I was not surprised. I'd already been through the triplet therapy, a stem cell transplant with my sister. I had relapsed and done donor lymphocyte infusion. I was always a believer that something was going to happen with the immune system. But it's a joy to see new drugs working with the immune system too. But now myeloma looked crowded. We had a multitude of drugs already in the field, and they were working really well. So then we had to build the Myeloma Investment Fund, which became our venture fund. And in that situation, we had to raise the money and then go out to all the immune biotech companies to attract them into the field of myeloma and help them do the testing. The reason that they came to us in myeloma was because we had the data sets, we had the samples, we could answer their questions, and we could give them the money. And when we blessed them, it was almost like a good housekeeping seal where people were like, okay, if the MMRF likes them, I bet everybody else will too. And that became a win-win for all of us. So, where are we now? Well, the American Cancer Society announced earlier this year that the 5-year survival for multiple myeloma has gone from 32% when I was first diagnosed to 62% today, which is remarkable. And for a rare disease to have gone this far, it's just extraordinary. But more importantly was a meeting that was held just 2 weeks ago, and it was supported by the International Myeloma Society, where they brought in every leading myeloma specialist from all over the world who presented all of their data on MRD negativity. How were their patients doing? And as they did this, they also brought in other cancers like testicular or lymphoma to say, well, how do you guys define a cure? And in that meeting, which I thought would never happen, we actually reached consensus that a cure for multiple myeloma is considered a patient who is MRD negative to the -6 without treatment for 5 years with clean scans. This is game-changing for us. The fact that we were able to reach consensus and define a cure means everything as you move patients forward for regulatory, for clinical trials, everything you want to do as we go ahead. It's also really important for patients because now there's a point in time where we don't have to be on maintenance therapy, which we ended up on drugs forever and ever. And if you can say now at the end of 5 years, you are able to go off, it is the biggest thing for a patient to be able to understand. So, during that meeting, I thought to myself, there's another big question that I definitely have. And that question is, if we went from 32 to 62 in 30 years, is it possible? Is it possible for us to get to 92 in half that time, in 15 years? And I believe it is. I truly, truly believe it is. But behind that big question of can we move much faster and get there, there are 5 other questions that came to mind for me. And they work in the area of early diagnosis, the ability to optimize what we have, the ability to see the white space of what we don't have, understanding patients where they are, and again, how are we going to partner, the most important piece of this. So let me just tell you the strategic plan of curing cancer in my mind as it is today, and what I hope many of us can work on together. So looking at, I'll go back one. Early disease. I was a smoldering patient with multiple myeloma, and they really didn't know what to do with me back then. Some people wanted to start treatment, others did not. And for the longest time, we did not treat smoldering patients in myeloma. But now we've actually risk stratified smoldering patients. And for the high-risk patients, we've started them on treatment. So the question becomes, if we actually know which ones are high risk, is that going to continue to grow? Are we able to make these smoldering patients MRD negative? And if so, how do we make sure that we're identifying the smoldering patients through EHRs so that the doctors know exactly who it is? How are we actually saying, this is the patient at risk that deserves treatment? Can we look at ctDNA? Is there going to be a point we actually start looking at high-risk MUGUS? What do we want to do in this field? But I will tell you one thing. If we can start achieving MRD negativity early on for these patients and not drag them through all of the treatments that people like me have been on, that would be the greatest gift we could ever give them. The other thing in myeloma is we have amazing drugs. We have bispecifics, ADCs, CAR T, you name it. The issue we run into as patients is we're really confused. We don't know the right dose. We don't know the right sequence. We don't know the right combinations, and neither do our doctors. And it's not bad intent. It's just because we're just all learning at the same time. So my wish for the future here is that we can actually share the data. And this becomes the tricky part again. I feel like I'm back to Compass 2.0 in designing this next model of where we go. But everybody has a great data set. Everybody has registries. Everybody can use real-world evidence. Are we going to be able to share this information, and can the AI companies come in as a trusted third party where we have the questions and we have to start validating them? I think so. I actually think that this is going to happen. And if so, how do we make sure that we're looking at everything from a retrospective to a prospective model? And how do we make sure that whatever we do in terms of identifying which patient should be on what, that we disseminate it to the community quickly, since yes, 70 to 80% of our care is in the community. And then the question becomes, what do we need next? Yes, we still need high efficacy for new drugs. We still need MRD negativity for our super high-risk patients. But really, when you look at myeloma now, it's more of a tolerability question. Our drugs currently have pretty high side effects. It makes them tough to have access to because it's not always easy in the community. Sometimes you need a caregiver to actually get you through the treatments. And in situations like this, we're now shifting what we're funding, for example, in the venture fund, to if you have a CAR T that can be off the shelf, we don't have to wait 2 weeks for the cells to be made. If we can reduce the tolerability, these are the things we're really looking at. But we're also looking at new trial designs, like adaptive designs, doing AI patient matching faster, and trying to make sure, as we find these new drugs in the place of unmet need, we do it quickly. And then we have to talk to the patients where they are. The patients of today don't look anything like the patients of yesterday. They are becoming much more educated. It's only going to happen more and more. When you watch how they get their information, first from their portals, then they can go right to AI and use it as they want to. And look, there are really good ways for patients to use AI to come to their doctor's appointment much more informed with much better questions. Then we can get them off to navigators, educators. There's so many ways to work with them. But as someone who's run the MMRF for such a long period of time, we have an entire navigation center at the MMRF, all oncology nurses. You'd be surprised at how few patients actually call us. I mean, when you look at the worldwide data in myeloma, you would think we'd have a staff of 10, but we don't. And part of that is the patients just don't always know that there are research advocacy groups out there like we are. So we have to decide, how do we make sure we start educating them faster so that they know all the resources available to them. And the final part is, if we're going to speed this system, and I was at the AI section today at the meeting, it was phenomenal. If we're going to speed the system, we have to accept the fact that AI offers unbelievable opportunities for us in every which way. So my hunch, and I know that I'll end up doing this partly with the MMRF, is the new models that we develop, you have to have the right players in the room. It's always going to be our clinicians, our scientists, our nurses, our pharmaceutical companies, biotechs, FDA. But you would be crazy in today's world not to know exactly which AI partners are going to come in and help you to put speed in the system. So that is my biggest focus, is understanding the entire AI landscape, which means that now we all, when we run advocacy, have to understand the science, the technology, the clinicians, the patients. But this is where the new models are going to come from. And when we look at these new models, it's going to be about how the money flows, because it always is. And so how do the incentives change? How do we give in? How do we work together to actually make this happen? And I would say for everybody in this room, if we can all be thinking about that in a really thoughtful way, we're going to make a lot more progress. So this is what we were doing in the field of multiple myeloma. But while all of this was going on and while we were moving forward in myeloma, I was dealing with my mother who had melanoma and was being treated at Penn. My identical twin sister had stage 3 breast cancer. I was diagnosed with breast cancer. My dad had died very early of kidney cancer. And I got a phone call from the dean of Harvard Business School. He'd gotten an endowment from Robert Kraft of the Patriots, and they asked me to come up and just start teaching how we did what we did at the MMRF and try to bring everybody together in the healthcare field. And that's what Mark was talking about. I spent 5 years up at Harvard Business School. It was the best job I ever had. I loved it because we brought in everybody from healthcare, and not just the advocacy groups, but all of the companies, FDA, and you name it. And together we shared every model we had. And we had 4 pillars: direct-to-consumer, data sharing and AI, adaptive trial design, and venture. I think they were well picked considering they were 5 or 6 years ago, because there's still some of the more cutting edge areas today. But I'm still a big believer in meetings like this one, where you bring everybody together that you can actually sit down and talk and share everything you know across cancers. Blood cancers are an interesting breed because we move fast. And how we can take that knowledge and move it to solid tumors, I think, is just equally as important. But as I was moving through my journey with breast cancer, I had to go back and read 30 journals that I'd written over 30 years, never expecting to live any of them and having written them for my children. And what really happened was I wanted to make sure that every patient had access to the same journey that I'd been on, because I was still surprised at how the system threw me off during my breast cancer diagnosis. Here I was completely educated, and I was still struggling and making mistakes along the way. So HarperCollins approached me and asked me to write the book Fatal to Fearless, 12 Steps to Beating Cancer in a Broken Healthcare System, which is why, as Mark said, I do spend a lot of time now out on the road speaking, and then working, of course, with patients to help them to understand how do you navigate this system. But most importantly, reading those 30 journals back, I realized how incredibly blessed I was. I did have a son. His name is David. He was born a year after my diagnosis. I did IVF at the same time I did cancer. And I do know where my daughter went to school. She went to Boston College, then followed me on to business school. And I do know who she married 18 months ago, her best friend. And the icing on the cake, I did watch my son play baseball all the way through college, and he got married 6 months ago. They are each other's sidekicks. They don't leave, they live right near each other in Brooklyn, and it is the greatest gift I could ever have. And it all reminded me of one thing. For patients, we spend so much time trying to save our lives that sometimes we forget to live them. And I think there were many times that I probably knew that that was my North Star, like having my family, creating the best memories was the most important thing I could do. But I was on the road. I was 24/7. I was urgent. I was damn gonna find that cure. And it's always how we all feel, right? Like, we're here in healthcare because we care so much about all the patients that we serve, and we sacrifice a lot. And so today, my message for you is that I hope we get to that 92 in multiple myeloma. But even more so, I hope we get to that 92 across all cancers. And there's only one way we're going to do it, and that's with all of you. I came here to say thank you, because you're the ones Thank you so much. You're the ones that make it happen. You're the ones that save our lives. You're the ones that understand us. So please know, and I talk about this and speak a lot at a lot of healthcare companies, and here's the reason why. We don't always get the credit we deserve for all the hard work that you do to save and extend lives. So I just hope you hear it directly from me on behalf of so many patients. You are special, you are amazing, and we appreciate it. Thank you.
What time? Okay, we have a 1 hour break, but it's not really a break. It's the abstract and exhibits time, which the majority of the abstracts and posters are on this side, all the way at the end. We also have something I don't think people are aware of. Right across from the abstracts is a little room called
has to make an intro, right? Okay. Well, sure. Come on up. Yeah. Okay, gang. Oh, you can see whatever you need.
Okay, so once she gets through all 37 slides, we're going to hit escape. And then all we're going to do is go to our PowerPoint.
Okay.
And then Michael Boudreau.
Yep. Oh, that guy right there.
You're going to be next. And all you do is click this button right here.
Okay.
Slideshow. And then
Okay. Oh, we're
then
good.
you're up
Okay.
there. If
Can
you
I
need
just look really quick to see if if my presentation is the one that I want?
yes, which one are you?
Madison, yeah, that one.
It should be updated.
Go to this slide. Yes. Okay.
Okay.
Well, I'm kind of thinking maybe after Danielle's done, she could put mine up.
Yeah.
And then after I'm done, whoever else can put their own up.
Okay.
I'm just playing. I'm kidding. I'm kidding.
Hey, Jake.
You just want to make it a little more interesting.
Hey, man, I'm lazy.
Yeah. But if you need help, just wave me over. I should be able to.
Okay, gang. Can everyone hear me? I know everyone's having a grand time. Can everyone hear me?
Whistle?
Okay, exactly. Do I have to hit a glass or something? Okay, so thank you all very much. I think this is like more people than came last year, so thank you very much. I am Mary Maluccio. I am the medical director of the Rare Cancer Program. And to put this in perspective, I joined CAGLA a couple of years ago, and predominantly because I was very much encouraged by their willingness to highlight some of the unique challenges of patients that are sort of marginalized and disenfranchised because they have unusual cancer diagnoses. So I have kind of used this platform to identify things that you would maybe not likely know about in any other track. So whether or not you know about breast or you know about colon or you know about lung, I think I've tried to use this platform to have all the stuff that you probably don't get on a regular basis. And so you can probably take some notes. So the first speaker is Danielle Paciera. She is, by popular demand, I have never seen more people raise their cameras and take pictures of her slides. She is what every person in this room needs to make us healthier and to live our best lives when it comes to nutrition. And what she has done over the course of her talks has really been invaluable for helping patients find nutrition resources closer to home, food banks, fresh vegetables, and things like that. And so I give her a lot of credit for really taking this on. And then I've got a couple of speakers. I've got Catherine Chang coming from our Shreveport campus, because we hadn't really touched on some of the unique challenges of head and neck cancer, and maybe where we could probably find more collaboration in how we manage some of those complicated patients. I have Michael Boudreau, who is an extraordinary dentist and PhD that does a lot of neat research in some of the dental implant work. But he is particularly important to our platform this year because our main legislative agenda for this year in CAGLA is to get dental coverage covered for patients that either need therapy or have dental-related complications of their therapy. So if people don't know, that is something that is often uncovered, and people don't have appropriate dental insurance, and so therefore they are either having unnecessary complications of their therapy, or in some cases like bone marrow transplant, can't even get the therapy without that either paying out of pocket. So that's Michael Boudreau. And then Eve Madison is the clinical director of our research portfolio and has been almost instrumental in getting industry-sponsored clinical trials to some of our very poor and disenfranchised patients that are either uninsured, underinsured, or can't afford the therapy that would be considered standards of care. And I think it's probably been one of our most successful things that we've been able to accomplish in the last couple of years as we have grown to take on most of the marginalized and disenfranchised patient groups of the entire U.S. Southern region. So without further ado, Danielle Paciera is going to give us all a very good lesson in dietitian and nutrition services.
Thanks, y'all.
So, if you've heard me speak before, you know this is an area that I love and am slightly passionate about. So, it really means a lot to me to have everybody here. The biggest mistakes that I'm going to discuss are really from the provider side, not necessarily from, you know, what we all do in our own lives day to day. And it was kind of hard for me to figure out where to start. So I figured I would start broader and work to the more repetitive, nuanced nutritional things as I go. My main goal today is not just to discuss the mistakes and to address those, but really to provide you all with a resource. So I will have a sheet of paper, or a pad of paper rather, up here at my table right there, and I'll have business cards and I have contact info in here. So if you would like a copy, so you have your resource packet. There are more slides than I intend to cover, and it's because I'm hoping that you ask for a little resource packet that I can send to you. And I have a long list of references like I do for every talk. And if you heard any of the previous lectures and you'd like any of those, just ask me for those and I'll send them to you too. So, where do I start? I'm starting with one of the biggest mistakes across the board, but especially in oncology, and it is not recognizing all of the different aspects going on at one time in a cancer patient's body. We know now cancer is multifactorial. It's not just, successive treatment doesn't just depend on addressing the tumor dynamics. We have to look at everything else that's going on. We know that there are profound metabolic derangements. There are profound states of inflammation. There's a whole emotional component. And we see different clinicians coming together on the physician side of things. We have medical oncologist, radiation oncologist, surgical oncologist, anesthesiologist, neurologist, gastroenterologist, but what's largely left out are the non-physician practitioners. And we can't address all of the things happening in the patient's body at one time as they're happening, which is at the same time in real time, if we don't bring everybody on board. So we want to have these multidisciplinary teams, but we want them to be specialists. Another big mistake I see being made is referral to hospital dietitians to get a patient in fast, to get them some care that's covered by insurance. But unfortunately, a lot of those hospital-based dietitians don't have that nuanced training in oncology, or they don't have the experience because they're newer in practice to be able to take these difficult concepts and really translate them into doable, rational, realistic goals for the patient and be able to guide the patient through different phases of treatment. We want to encourage people to refer early to the different clinicians in the team. And cachexia is a really good example of that, and a really good example of why we need specialists. When cachexia gets going, it's like an avalanche. I spoke about this last year. The faster the ball rolls down the further the ball rolls down the hill, the faster it gets going, the bigger the ball gets, and it's from a little snowball into this big old avalanche, right? The same thing happens with cachexia. It starts, it's not as bad, but then once you get to a certain point, it's not going to respond well. And cachexia is one of the leading causes of death among cancer patients. And what do you do as a dietitian treating a cachectic patient in a hospital? You give them booster and sure, right? No, wrong. You don't want to give people that. It's very bad for cancer patients. It interferes with proper nutrient absorption. It drives inflammation. And cachexia is not a condition caused by lack of calories. It's caused by many other things. Like I said, I spoke about this last year, so I'm not going to spend a lot of time. But this just speaks to the need that we need to work with clinicians excuse me, who understand how to address all of these different aspects, that know to look at genetics. We have great genetic testing companies, novel companies here, that know to look at labs to get an idea of what's going on a metabolic level, on an inflammatory level, on a nutritional level. So when we ignore that role of inflammation, we don't just interfere with proper treatment of cachexia, we interfere with the body's ability to do what it's supposed to do. What is the immune system supposed to do? Detect mutant cells and eradicate problems before they turn into full-blown cancers. Well, inflammation can interfere with that. Micronutrient status also profoundly affects the body's ability to regulate the immune system. And I'll speak to this in a second, but we have this really vast misunderstanding of what malnutrition really is. Understanding the importance of plant-based nutrition is really important, not just to get those micronutrients, but because there are thousands of plant-based compounds that may be just as essential as the nutrients, and you'll see this as we continue to go. But what happens so often is we feel bad for cancer patients. We want to make sure they get their calories up and keep them up. So people say, oh, eat whatever you want, just make sure you get enough calories. Well, that's not going to help, because if they're eating inflammatory foods, it's going to drive these processes that are driving tumor-promoting environments more, and that are going to drive down the quality of life. Different nutrient insufficiencies cause lack of appetite. Some of them cause fatigue. Some of them cause brain fog. How many people with brain fog and fatigue are going to be able to make themselves food they want to eat? Not many. Discouraging supplementation. When a person has a micronutrient insufficiency, rarely is diet going to be able to alone address that. And if you look at what's in the literature, the overwhelming support is in favor of proper supplementation. There are supplements that do pose concern. I'm not going to say there are not, and there's a lot of crap on the market. So wise supplementation is key. If you tell your patients not to take supplements, they're going to take them and not tell you about them. I see it all the time. My patients tell me, oh, my oncologist told me not to take this. And they put on their intake form all of the supplements they're taking. Still, 90 to 95% of cancer patients, whether they've been told to take supplements or not, are taking them. So it would behoove you to have an open dialogue. Not everyone is trained in this area, not every nutritionist, not every physician. So you need to seek out people to refer to guide these patients so that they are not doing more harm than good. So back to malnutrition. We have this idea, at least if you were like me, you were taught malnutrition is protein or calorie deficit. It's way more than that. There are 15 essential amino acids, 2 essential fats, the omega-3s, the omega-6s. There are 13 essential vitamins and 16 essential minerals. That's 46 nutrients. So malnutrition can occur with an insufficient, not necessarily a blatant deficient, but just deficiency, but an insufficient level of any of those. And that's going to impair inflammatory modulation, immune regulation, for sure, quality of life. But what complicates things is not just poorly recognized concepts of what malnutrition is. Even if people get it, like we need to look at micronutrient status, a lot of people don't understand that it's not as easy to do as we think it is. What do most people do? They order serum levels of this or that. Well, many nutrients can't be measured in the serum. Zinc is a good example. Serum zinc doesn't reflect tissue levels of zinc. The serum levels are going to be maintained at the expense of the tissues. But if there's not enough in the tissues, the body can't do what it needs to do. And serum zinc is influenced by meals, time of day, the way the blood comes into the tube, what's happening to the tube after the blood is in it. Infection, inflammation can all alter what's on the lab report for zinc. How do we measure for folate deficiency? CBC, that's what we were taught. Well, there are many different types of anemias. Some of them make the MCV go down. You can have a thiamine, a B6, a zinc, a copper, an iron, a B12, a folate, B6, so I said that one, riboflavin. They're all going to skew different biomarkers in the CBC different ways. So how do you know what to order? Because if you start ordering red blood cell zinc, red blood cell magnesium, red blood cell folate, methylmalonic acid. You can drive the out-of-pocket expenses up. Well, this is where the expertise comes in, and really experience and being able to listen to pick out certain trends. How many people in here have patients with diarrhea? Yeah, zinc deficiency symptom. Is it the only thing that can cause diarrhea? No. How many people have a patient in here with low mood, apathy, brain fog, maybe difficulty healing, poor immune function? Anybody? No? Yeah, some of you. I mean, it sounds like a cancer patient. Well, that's all a cluster of folate deficiency symptoms or insufficiency. So when you learn to listen for certain things, you learn how to make appropriate lab orders to not drive these things into such high cost areas. So a lot of different cancer drugs have targets, right? Well, if you look at this slide, you see a lot of nutrients going into those target areas. So nutrition has a huge role in how the drugs can behave in the body, whether they're tolerated, what their response is. It has a huge impact. I can't emphasize that enough. Why is that? There are many different reasons, and I'll touch on those in a second, but almost every drug, especially cancer drugs, can deplete nutrients, and it's especially true of chemotherapeutic agents. They affect almost every vitamin and the majority of minerals. So what I did is I researched primary cancer treatments, prescriptions, and then for each one of those drugs listed, and there were many, I researched depletions for each of those. And that's how I came up with this list. So this is a list of known, documented in the literature, depletions of nutrients caused by the primary cancer treatments. Is not a small list, and any one of these insufficiencies can interfere with the ability to respond to the treatment, to tolerate the treatment, to liver function, which is going to impact toxicity, immune surveillance, inflammatory modulation. So this is a list of symptoms, and the next two slides too, caused by insufficient levels, again, not deficient, but just simple insufficient levels of the nutrients you just saw. More in the musculoskeletal, systemic, those that are a little bit more generalized to the gastrointestinal tract. So even if we're not talking about drug tolerance, drug toxicity, quality of life, you can't tell me if a person has taste changes or nausea and vomiting, they're going to have any quality of life. Sure, they're not. They're not feeling good. And we have a huge impact when we bring nutrition on board in quality of life. Nutrition is never, ever, ever neutral. It helps or it harms. Like I said, it influences tolerability. So if we improve tolerability, we improve full completion in a timely manner. We know that the majority of cancer patients are presenting at the time of diagnosis with multiple insufficiencies. And the stage of cancer is directly related to how malnourished a patient is. And that's not just the degree of a vitamin or a mineral insufficiency, it's the number of vitamin and mineral insufficiencies occurring at the same time. So what happens when these patients have poor nutrient status? Obviously, increased rates of noncompliance, treatment, sorry y'all, the oak pollens, treatment, what's the word? I have horrible word recall. They stop their treatment and don't ever go back to it. Higher rates of complications, especially surgical interventions. We see more post-operative problems happening, and what does that necessitate? That necessitates hospital stays, or longer hospital stays, or returned hospital stays. I don't know about y'all, but typically, at least with my patients and with my family members who have been patients of other clinicians, the goal is always keep them out of the hospital, get them out of the hospital as quickly as we can. But it's not just about the importance of nutrition during treatment, before treatment. Nutrition is going to, at the get-go, define how a patient responds to chemotherapy and many other prescription-based therapies. But we have to look at the other end too. If a patient was eating a poor diet that drove cancer, I'm not going to pretend like diet alone can cause cancer, but it definitely has a huge impact. 90 to 95% of all cancers have diet, lifestyle, and environmental roots. We know this. That's why there's been a tobacco campaign for decades. But look at this. 25 to 30% of cancer deaths are caused by tobacco. And yet 30 to 35 at a minimum are affected by diet more than genetics. So it's really a big, big thing we need to start looking at. If it helped the cancer ensue and progress once, it'll do it again. Secondary cancers. How likely are they after there's been a primary? We know that there are certain foods that are more associated with cancers. Meat is what's often said, but it's not just all meat. Conventional meat, processed meat, ultra-processed food. But a bigger part of that is lack of plant-based foods that have all of these micro and macronutrients, all of these plant-based compounds. You've probably heard this. It's one of my favorite quotes, so I jumped at the chance to use it. Hippocrates also said all disease begins in the gut, and I'm really glad Mike is following me, because one of the things that I always tell people is it's not just what you eat. It's what you eat, what you digest, what you absorb, what you assimilate, what your cells can uptake. But there's a lot more that goes into nutrition status than that. Emotional states. Yes, we know stress can cause profound states of disharmony in the body. It causes inflammation in the gut, increased intestinal permeability, microbiome perturbations. But it's beyond that. What is a person's ability to care for themselves? What is a person's will to live? What is their relationship with food? And this is where the multifactorial approach comes in, multidisciplinary teams. I can't address all of those, so what? I refer to a counselor. There are certainly muscle dynamics involved in cachexia. I can't address that, so I refer to physical therapists. Even if a person has great digestive system function, if there are pelvic floor issues, there's going to be some digestive issues that occur. So I refer to a pelvic floor physical therapist. And then the microbiome certainly has a huge impact on what we can digest, what we can absorb, inflammatory states, but even more so, the microbiome tells the immune system what to do. So it has a profound impact on immune surveillance. Another huge mistake is patients want to be told what to do, so they want to know what diet to follow. There's not one that fits everybody across the board. There are different diets that have been shown to have tremendous benefit. I was listening to a podcast by a very prominent researcher, a very well-known name this morning, and he is a really strong proponent of ketogenic diets. And I think they're great. My mother was on a ketogenic diet. It wasn't easy as the cook, but it did have some benefit. But you know what? I've seen patients really flail on a ketogenic diet. One thing that all of these diets have in common is not the macronutrient distribution. I've seen people flourish on Gerson diets. That's like carb to the max. The ketogenic diet is like no carbs. The thing that they have in common is what they include. And that's a lot of plant-based foods, a lot of these colors, a lot of these aromas, a lot of these phytonutrients that we're learning now are just as essential as the essential vitamins and minerals. They tell our genes what to do, how to work, how to behave. There are 25,000, and the list is growing like every day, compounds that have been shown to have cancer preventative and I want to say eradicative because I like to make up words, but promote eradication of cancer cells. Yes, a lot of those are cellular-based studies, but we also see in clinical trials done with diet, it's really hard because you can't double-blind a diet trial, but we're seeing promise in these areas too. Remember that slide I just showed with all of those different targets of the primary cancer medications? Well, a lot of those plant-based compounds target those. But if you start to think about the fact that one food has thousands of these compounds in them, you start to see the real potential that plant-based foods have. And when I'm saying plant-based foods, I'm not saying be vegetarian. I'm just saying eat more plant-based foods like fruits, vegetables, nuts, seeds, herbs, spices, legumes, for some people. But unlike the medications, they don't have the negative unintended effects. In fact, they improve other areas, inflammatory modulation, reduced oxidation, antioxidant benefits, metabolic benefits, energetic benefits, mitochondrial support. So, where we've gone so far, I'm not going over it. When you get your resource pack, you can read this list, which is continued on this page. So what I want to do is switch gears and talk about what to do with all of this stuff. Because let's face it, if you have a patient, they're going to be like, well, what should I eat? What do I do? Well, you want to first refer to a nutritionist right away, somebody who knows their stuff. But the ideal and the reality don't often happen at the same time in the way we would like them. So sometimes there are transportation issues. Virtual practices can get around that now. That's one good thing that came out of COVID. Another thing that is an impeding factor, wait lists. Getting in with a clinician when you want them to be in. And then they're going to be like, I can't get in for 6 weeks. What should I do? What should I be eating? If nothing else, tell them, think about color, think about quality. So, shove every bite full of vitamins and minerals and healthy fibers, microbiome feeding foods, colors, aromas. Eat a rainbow of foods. Shop seasonally. But at the very least, half of what all of you, not just your cancer patients, should be eating should be ideally vegetables, plants, heavier in the vegetables. A lot of cancer patients have undergone treatments or procedures that increase their protein need. So for these patients especially, they're going to need a little bit more protein, at least a quarter of the plate. And then, carb intake is controversial in cancer, but we know that most Americans get too much. So a quarter at most of the plate needs to be carbs. Healthy fats are crucial. They help regulate the inflammatory modulation and cascades. So one of these slides, the top one, is a slide from last year and probably the year before. The bottom slide is what this looks like in practice. It's not as hard as people think it is. I went to dinner Monday night and someone had a plate delivered to the table. It was a different fish, it wasn't salmon, but it looked a lot like this one. So if we're seeing it on restaurants, if we're seeing it on the internet, you can have it in your house. It's not hard if you can teach people a few basic kitchen skills like batch cooking, bulk cooking. When they have higher energy levels, they roast a whole bunch of vegetables. They throw it in the fridge. They slice up some radicchio. They keep some avocados on hand. Then, when it's time for dinner, you just pop that salmon in the toaster oven for 10 minutes, grab your little Tupperwares, heat it up, slice up your radish and your avocado, some herbs, sprinkle it on top, and boom, it's so pretty and tasty. Once they're skilled at that, you can tell them the more nuanced thing. Eat 5 colors per meal. Eat from a farmer. That means seasonally. Include at least one therapeutic food per meal. What is a therapeutic food? Cruciferous vegetables for cancer patients vary. Anybody with digestive disorders, those bitter vegetables, radicchio, arugula, watercress, endive, escarole, artichoke, the thistle family. Culinary herbs and spices, can't say enough. And they make everything so much more fun. If you don't remember anything, eat a rainbow. If you don't remember anything else, eat food from a farmer, not a factory. If it goes to a factory before it's on the plate, if it changes shape from what it looked like on the tree or on the bush, it's processed. Processed food has no place in anyone's diet, except in small amounts, because we all like cookies, or especially cancer patients. But more than anything, you have to have fun with your food. It doesn't have to be boring. There's a learning curve for some people, but in the end, a lot of my patients come back and they say they feel better than they ever have before. They don't want to go back to the way they were eating, and they're enjoying food way more now than they ever did before. So they don't want to go back because they don't feel like they're missing out. And that's what I want to leave you with, is it doesn't have to be boring, it doesn't have to be tedious. It can be fun and it can be really enjoyable. So come see me after. I'd love to share the resources and the whole lecture and any other lectures with you. And thank you very much, y'all.
Hard act to follow. You were so organized and informative and everything. I tend to wing things a little bit more. I think the first thing I'd kind of like to mention is how I ended up here. So I'm on this thing called the LDA Legislative Affairs Board. And so we vote on things for dentists and making laws and all this stuff. It's typically very boring, dry stuff. And so we have a quarterly meeting, and I go up to Baton Rouge, and we all meet together. And 2 meetings ago, I think it was, Annette Drawdy, who's the person that runs this thing, goes, hey, we had these doctors and this guy, Chad, call in. They're talking about trying to get legislation passed where we could actually get, teeth pulled and treat cancer patients that are going to have chemo and perhaps have the medical insurance pay for it. I woke up. I mean, I just went, oh my God, this is great. We treat people all the time. That's one thing we kind of forget about, right? We need, prior to people getting treated for, for cancer issues, before going radiation therapy and chemotherapy and all this stuff, you got to make sure that their mouth is infection-free, because we don't want this stuff popping up when they're halfway through treatment, and then how do we deal with it at that point? So one of the problems, though, is insurance. Patients just can't afford a lot of times to have this simple thing, really basically a simple thing taken care of prior to their treatment beginning. So we're working on legislation to make that happen. And so that's a big deal. It really is. And thank you for kind of putting me on the spot going, this is our most important piece of legislation this year. Dr. Boo, yeah. So it's huge. It's huge. And I hope we can get this thing to go through. The other thing is, I didn't have lunch today. I don't like to eat too much lunch. I'm a eat dinner, in the evening kind of guy. And Danielle made me really hungry, so I'm gonna try to make this short so I can get a nice, broccoli or something of that nature. And you'll also notice that my slides, they're kind of dry. I don't have any pictures or anything like that. Typically, my audience that I speak with are dentists, right? And when I get dentists in front of me, man, I got videos, I have 3D renderings of teeth, all this fun stuff. I'm not gonna bore you guys with that. I just want to drive home the importance of oral health with the cancer patient, everyone. But a lot of times patients will just kind of put that off, neglect everything, right? Until it becomes such a priority that we have to deal with it immediately. So, and I'm going to flop around a little bit. I'll try to go through the slides, but for the most part, the take-home message with this is, once a patient's diagnosed and they're going to need treatment, get them to a dentist, right? I mean, and I'm going to say this as gently as I can. Try to make sure, if you can, to have the patient do a little research on the dentist that's doing their work. You want to get somebody that's going to be concerned about getting them healthy and getting them through this huge hurdle of treatment, as opposed to trying to make a few bucks off of it. I'm just being honest, right? My wife gives me a hard time all the time because I'm always pulling teeth for free, right? One day I'll end up living under the bridge with that guy that I wanted to give $2 to earlier. But anyway, let's move on here. So the title of my talk is Oral Health Management and Rehabilitation for Patients with Oral Cancer. This doesn't necessarily apply specifically to oral cancer, cancer in general, cancer that we're going to be treating through various methods, radiation therapy, chemotherapy, whatever method, surgical therapy. We need to go ahead and manage these patients before we start on those treatments because we can have some problems. So our learning objectives are to recognize the oral complications of head and neck cancer therapy. The biggest thing that we see, and man, it's kind of horrible. Teeth are a big deal, right? You can't eat without your teeth, you can't smile. But in addition to that, oral mucositis, I mean, this stuff is just horrible. These patients aren't able to, I mean, it's the most miserable thing I've probably ever seen in my life, right? Then, in addition, we have the added fringe benefit as being dentists, you have uterine cancer, kidney cancer, brain cancer, all these things. We have the additional fact that a lot of times the patients, after we make them an obturator to kind of fill the hole in their jaw, they go, can you make it whiter? So it's something that everybody sees. But we want to recognize the oral complications, understand the importance of pre-treatment dental clearance, making sure these infections are taken care of. And I'll tell you now, if a patient comes to me and a tooth looks at me crooked and they're about to go through radiation therapy, I'm getting that sucker out. I mean, I might have a filling that normally I'd go ahead and just say, fill the tooth, right? In this case, the biggest thing is just to make sure there are no complications during their treatment. And then I review some prevention strategies for radiation complications and understand prosthetic rehabilitation options. That's my favorite, right? I hate to see these people going through this stuff, and I want to do my best I can to get them better. So prosthetic rehabilitation options are, if there's an oral antral fistula, this big hole where they're eating and the food's going into their sinus cavity, I'm going to make them something where they can eat again. And that's a huge thing. And I'm a builder. I'm a builder by nature. And so why oral health matters, I'm just going to say, hey, Danielle told us all about that. I'm not going to go through it. We all know why oral health matters, right? Especially just in the regular population, but especially in patients that are undergoing some type of treatment. You guys know a lot more about this part than me, right? All the different modes of treatment. The big thing I see, our biggest thing, I really worry about radiation therapy in the head and neck region. We just see some stuff. A patient could be eating a Dorito and they show up at the office and they have a piece of bone sticking out where just this minor injury caused a serious problem in the area of radiation therapy. Let's see. Boom. And I'm moving a little fast because I know I have a few slides in here. I don't want to hold this up too much. So yeah, up to 90% of radiation patients develop oral complications. Probably everyone I've ever seen that had any kind of head and neck radiation, their salivary glands are shot. You're just seeing a lack of saliva. They're not actually able to produce saliva. So it's a rarity to see someone that isn't having some kind of issue with it. Oral complications can interrupt therapy, right? We don't want that occurring for sure, because if you can't treat them because of this oral infection, it was something we could have proactively treated. We definitely don't want to run into that. And then pain and infection, impaired nutrition, right? They can't eat, they can't get the proper vitamins and all that fun stuff. Here's the other thing too. Who doesn't like to eat, right? You get a patient in that maybe hasn't had a meal. Where they're to the point, I have this one lady, they were getting ready to put her on a feeding tube, and I'm going, this is horrible, horrible, horrible. That was a couple of, late nights to midnight working to get her taken care of. And then early dental intervention improves outcome. If we can get to them early on, then maybe we can do something about it. So pre-treatment dental management. Recommend 2 to 3 weeks before radiation. We just want to get in there and get it taken care of. You guys are on a timeline. As soon as you decide that you're going to have this patient going through treatment, we're in a rush. We're going to get this stuff done. So a lot of times that's why we aren't doing root canals on maybe savable teeth. We might not know the potential outcome for a month or 6 weeks, because sometimes you'll do a root canal on a tooth and guess what? It didn't work and you got to pull the sucker. We don't play that game. We get them out of the way. You eliminate infection in unstable teeth. If I look in the patient's mouth, I think it's bad, it's coming out. Reduce osteoradionecrosis risk. You don't want to pull a tooth after they've had radiation therapy. You'll see some horrible things going on. And to educate the patients on oral hygiene. A lot of times these patients will be in a removable prosthetic, a denture, right? And they aren't cleaning that thing, and that food's getting stuck in there, and it's rubbing against the mucosa. And without undergoing any kind of therapy, it's kind of a horrible situation. You have to educate them. You have to get them cleaning that stuff. You have to get them cleaning their teeth. You need to monitor them. You need to have these patients come in every 3 to 4 months maximum, post-treatment to make sure that things aren't getting out of control. Let's see, next one. So teeth often removed before radiation. Like I said, here's a list of things, but if it is suspect to me whatsoever, we're just going to extract it. And, I'm not saying I'm going to go pull a whole bunch of good teeth out of an individual, but we just don't want to take any chances that we don't need to take. One of the big things that we see is oral mucositis, right? So their salivary glands are kind of shot, right? Nothing's working right. And look, this stuff is so painful. I'm sure you guys see this quite a bit, right? And it's really hard to do anything that can alleviate their discomfort. I'll usually recommend, to start something simple. I'll do baking soda, salt, and water, have them rinse with that, see if that helps. If not, we'll put them on some Magic mouthwash. It has a little bit of lidocaine and steroids and stuff, but it's still a rough road. The cleaner they keep their tissue, the better they take care of their oral cavity, the better their nutrition is, the less likely that you're going to see these things. We do need to manage them at some point, but, see, I'm turning that into you need to manage it, no, it's my job. It's just a huge thing. And the xerostomia, in general, in dentistry, problems with teeth come from problems with the salivary glands, right? Either they're not functioning properly, or the immunoglobulins being produced aren't in the right ratios, and you're not getting bacterial destruction like we should. We're not keeping their immune system in check. And so once you destroy the salivary gland or make it not function as well as it should, you're gonna see these issues. So even in a healthy, non-treated individual, medications, Danielle mentioned medications, even blood pressure medication can affect the salivary glands. And once the saliva isn't being produced the way it should, oral hygiene becomes much more important, but it also becomes almost a losing battle a lot of times to be able to maintain their teeth, You think, I go to the dentist, I'm going to get a root canal, I'm going to get a filling or whatever, and it's going to be better. No. This is kind of like, we always call the lower first molar in an individual the money tooth, because we'll go in, we'll fill it, then we'll go back, we'll do a root canal on it, and we'll crown it, then we'll pull it, then we'll put an implant. And it's just this sequence of events. We do our best to maintain the dentition as long as possible, but anytime you start undergoing treatment for the dentition, you're kind of living on borrowed time, And so this is something we see radiation carries with radiation therapy. You'll start to see decay around the margins of the teeth. So the reason we want to have them come in often, every 3 to 4 months, is we want to be able to detect these lesions as early as possible. So what we do in a case like this, if we can catch it at this point, we have fluoride-releasing materials that we can actually put in those decayed areas of the teeth and kind of try to maintain them and keep them from getting worse. And we may have to repeatedly, take these out, put them back in, but we have to maintain constant vigilance on these teeth in order to keep them as healthy as possible. Once we're down to that level on that picture on the left, we're really having some trouble. If that patient underwent radiation therapy and the teeth have gotten to that point, what are we going to do? We're going to pull them. Sometimes we'll take an individual that's in rough shape like that. We'll do root canals on all of the teeth. We won't restore them. We won't put crowns on them. We just get the nerves out of the teeth and try to hold on to them as long as possible so we don't have to do the extractions on them. And so frequent dental monitoring, very important. Yeah, if we see in patients treatment over 60 grays, hypovascularity occurs. When the blood supply isn't getting to the bone well enough, any little injury that causes a disturbance in that bone can really cause some serious issues with osteoradionecrosis. And, I've had a couple of patients come in where, by the time they finish cleaning this bone out, the surgeon will go in and debride these areas. I mean, you lose the teeth, you lose, 25% of the jaw on that side. We're looking at making some kind of dental prosthetic. It becomes kind of difficult, right? So minor trauma can cause some bone necrosis. It can be very, very difficult to treat. So we also have functional impacts after oral cancer surgery. So we will find a patient's speech even is affected. If you have a communication between the sinus cavity and the oral cavity, and I'm gonna kind of give you an example. It kind of sounds very nasally, where you really can't even understand what the patient is saying. So we need to close that hole up so that their speech. And it blew me away. The first one of these cases I worked on, I was like, wow, it's so bad. The mouth and the nose, the vocals, very much like a musical instrument. Like when you go, oh man, if this thing isn't just right, it doesn't work properly. So you have to have some mechanism to go ahead and correct that speech impairment. Mastication difficulties, you can't eat if you can't chew, right? I've seen some people without teeth eat some insane things and they got by, but it's not recommended. Swallowing impairment, the food will go into the nasal cavity, patient just can't eat. And loss of facial support, you're going through cancer, you're going through this most horrible thing in the world. Now you're cosmetically things are going wrong. So that's a component of it. It's, keeping them healthy and everything, but we also want to try and make them as happy as we can as well, do what we can. Obturator, so this is an example. This is a patient. This is Miss Hazel. I saw her yesterday. In fact, she came in for a little adjustment. I didn't know she was coming in. I was like, oh, hey, Miss Hazel, she came in, she could not eat, it was rough. And so we probably made her about 6 different devices before we found just that perfect combination of things. And so my lab technician called her a couple days ago, and she said she had something going on, a little sore spot. He took a drill bit and cleaned it up. She's doing fantastic. She's gained weight, she's doing good. She's eating, she's happy. Her speech is fantastic. I can understand everything she says. And so that little picture on the left is, we computer designed these things today. It's so cool, like with her. So look at this defect, right? See that big old hole? Try to take a dental impression of that. Anybody ever had a dental impression taken for a crown or something, right? You can stick that way in that hole, and that's how it used to be done. What I did with her was I took a cone beam CT scan of her. I created an STL model of her soft tissue from that scan. Then I digitally built that device on top of that scan. Then I took this thing and I milled it out of a material called Duraflex, which is a flexible material. Then we relined it in the cavity to seal it up. And yeah, she can eat now. That's hard to fix because all that back area, kind of by where those bottom teeth are, that's flexible. Every time she swallows, this stuff's moving, and so we had to go through different materials and stuff. It made me very happy to see Miss Hazel yesterday. And you know how much we charged her? Nothing. I'm not going to send her out with that. I can't do that. But it'd be nice, and not just for my office. Isn't the whole? It's so other dentists start treating these patients. It's a big deal. And a lot of people that's going to do it for free. I'll tell you that. So implant-supported rehabilitation, not always an option in these cases, but Miss Hazel, for example, I wish I could go back in time. And so she had radiation therapy and surgical resection of her cancerous area. If I could go back in time, in that time period before radiation therapy and surgery was performed, if I go back in time and stick one implant in her, one dental implant, and then start treatment a few weeks later, then I actually have something I can snap the prosthesis on night and day, right? So when I say try to get them or help them research, maybe I could even make a list for you guys or something, dentists in the area. that are going to think outside of the box like that. The surgeon I work with and we were just talking about this with another patient the other day. I think we're going to go ahead and do it maybe next week. Get the implant in before everything happens, and then we're gonna make their life a lot better just by being proactive about it. But so implants, you know, we take these teeth now, we screw them in, all kinds of fun stuff. And a healthy person, yeah, we can do a lot. And a patient that's getting treated, it's difficult. And then long-term care, like I said, we want to see them every 3 to 4 months. Daily fluoride therapy, we'll make them some fluoride trays if they still have teeth, that they can put some fluoride gel in and cover their teeth to try and minimize the occurrence of caries. Monitor for complications. We just gotta keep looking at it, especially a patient that's wearing a removable prosthetic. That the tissue will change over time. And so with that removable prosthetic, it's almost like taking a pair of Dutch wooden shoes that you're wearing, and we're just sitting here trying to keep those shoes comfortable for that patient. So you have to get them in. A lot of patients, you'll give them a denture, you'll never see them again. These patients, you gotta come back. You can't just go, yeah, it's a little sore. No, tell us, get you in. And so we gotta monitor them for complications, and then maintain prosthetic restorations. We gotta take care of their teeth and their dentures. So this is just a list of, you know, who's involved with this stuff. Kind of the way I work the system at my office, which hopefully, this is all a learning process to some degree. The reason we started seeing a lot of these patients is because, like I said, I'm a builder, right? I'll build anything. And so the surgeons in Homa got wind of that I build stuff, and we have a dental lab. And so they just started sending patients over to us to correct things, right? So we typically work, if I have a case, you know, suspected oral cancer, we'll send it to the surgeon, or another dentist will send it to the surgeon. So we really don't have any interaction with the oncologist. The oral surgeon interacts with you guys more than we do. But, you know, at some point, I would like to be able to maybe get, you know, a little bit more education and learning and, you know, building a better network so that maybe we can work with people, nutritionists, right? In fact, I need to talk to you about a diet for people that their implants get rejected. Thank you. And then speech therapy and nutrition, we do have a speech therapist available. We don't use her too much. We can usually, if we do the prosthetic right, and get the form of this thing right, we could usually get their speech in-house much better. But yeah, it's a team effort, just like you guys, you know. And key takeaways: oral complications preventable. We just got to make sure we're looking out for them. Pre-treatment dental clearance is critical. Make sure you get that done. Don't forget that, right? Of course you won't, right? But still. And then, you know, collaboration between you guys and us. And the rehabilitation restores function and quality of life. And I'm just waiting for Miss Hazel with her little prosthetic device that I built her to tell me that she wants her teeth whiter or something. And so this is my final slide. So I'm sitting in my office. I work a lot. It's okay. It's okay. And I'll leave you with this little story. When I was a kid, and I've done a bunch of stuff, you know, I did engineering at one point. I used to work on cat brains. I was a researcher at Tulane for a while. I've done a lot of stuff. But it was one Sunday, and it was nice, a couple years ago, right? Really nice day outside, and I'm in my lab. I'm working, building some teeth, you know. And I'm just, man, I want to be outside so bad. I just want to go fishing, whatever, right? And then I'm sitting there, and I have one of my, in fact, I think all 3 of them are going 3D printers, 4 of them, whatever, making noise. I hear my milling machine in the back. I have my CAD software up on my computer, and I think back to when I was a little kid, that I liked chemistry and I liked science. And I go, man, quit whining, right? You're doing exactly what you wanted to do. Shut up and get to work. And ever since that day, I went, I got this, and I do it. And I enjoy it. It took that moment of clarity to go, nah, this is fantastic. And if we can help people doing it, and I'm not just talking about the routine stuff, the cosmetic dentistry. I let somebody else do the veneers. That's not, I do them if they beg, you know, and I say, I don't want it. But the thing is, we do a great job too, because we have our own lab. So this is probably around midnight one night, right? And I just had this model. I was painting the little gums on it, screw-in teeth. And it was laying on my desk. And then there was a copy of the law we were talking about, the draft of the law. And then back here, See that little thing that says Ochsner Health back there? That's something to do with this convention. This is midnight one night. I laid this thing down and I looked at it. I said, take a picture of that. Take a picture of that. That's kind of where, that's what we do at my office. And we would hope that you can find dentists that will do the same thing and be into it as much as we are and get your patients taken well care of. All right? And I think I'm going to let you guys take a nap now, if you haven't already. Thank you.
You said you weren't going to. All right, well, thank you for not taking a nap, and for those of you who stuck around. Today, I'll be talking about some of the barriers, breakthroughs, and the path forward in clinical trials, and I'll talk specifically about some challenges and advances in neuroendocrine research. I have no disclosures. My objectives for today, I will discuss clinical trials and why they matter, specifically in rare cancer. I'll briefly discuss the life cycle of clinical trials, talk about some of the challenges faced both by patients as well as researchers when dealing with rare cancer, what the patient experience looks like and how we can improve upon that. And then I'll spend the last part of my talk talking about the neuroendocrine trials that we currently have within the rare cancer program here at LSU, just to try to bring some awareness to what is actually available here for your patients. So before we start discussing trials, I'll just give a very brief overview of neuroendocrine cancer. Neuroendocrine neoplasms are rare, but like other cancers, they are on the rise. In fact, we've seen a 5-fold increase in the past 5 decades. And this is partly due to better and improved detection and earlier detection. So neuroendocrine tumors are a heterogeneous group of neoplasms. They are located throughout the body in neuroendocrine cells, most commonly in the gastrointestinal tract, but they can also, and pancreas, but they can also occur in the thymus, the lung, and less commonly in ovaries, heart, and prostate. Well-differentiated nets strongly express somatostatin receptors, predominantly the SST2 subtype, and this is the actionable target for many of the therapies that are available to this patient population. Neuroendocrine patients present with what can be vague symptoms that include bowel changes and pain, diarrhea, flushing, fatigue, and these symptoms are often attributed to more benign conditions and as a result causes significant delay in diagnosis. In fact, I think it's on average about 5 years from the time that patients present with symptoms that they are correctly diagnosed. And as a result, 40 to 60% of patients that present with neuroendocrine have metastatic disease. So surgical resection with curative intent is the frontline treatment for localized NETs, whereas disease that's become metastatic requires systemic therapy and may also involve surgical interventions for symptomatic control. The systemic therapy includes your somatostatin analog, the both short-acting and long-acting. This is your octreotide, lanreotide, and some targeted agents, including sunitinib, everolimus, and the newly approved cabozantinib. Additionally, PRRT, lutetium-based PRRT, is a systemic therapy that is used when patients progress on somatostatin analogs. Despite these therapy options, there is a clear unmet need for additional therapies when patients progress. So why do clinical trials matter in the rare cancer space? These trials play an essential role in bringing access to emerging therapies for this patient population that wouldn't normally be available to them. Additionally, these trials bridge the gap in rare cancer biology. Compared to other cancers, there is significantly less investment in these types of cancers, and clinical trials can by bringing participants in, can accelerate discovery. Clinical trials can also enhance patient care in that they connect patients to specialized centers offering multidisciplinary support and advanced symptom management. Importantly, clinical trials are a very important mechanism to improving outreach and reduce disparities by ensuring diverse patient representation in research. And in an increasingly difficult healthcare coverage landscape, clinical trials offer treatment options to patients who may not have access to treatments, including standard of care. Oops, sorry. I'm not sure what happened there. Boy, I really jumped ahead. Okay, sorry about that. Clinical trials also generate the evidence base that drives standard of care, as well as policy and guidelines in this patient population. So just very briefly, I'll talk about the life cycle of a clinical trial for those of you who are not involved in these studies. In phase 1, these are done in a small patient population. They're focused primarily on safety and focusing on side effects. In phase 2, there's a larger patient population, and with the goal of determining initial effectiveness, as well as closely monitoring side effects that may develop. Phase 3 trials are large-scale trials. They usually involve multi-site cooperation. They are randomized and controlled to confirm effectiveness and compare against the standard treatments. And this is where a company would file for an NDA. In the event of a successful phase 3 trial, we would complete a phase 4 or post-marketing surveillance trial. The purpose is to determine long-term safety and efficacy and potentially guide in a real-world setting and potentially guide any labeling changes. So, which sounds simple enough, but only about 4% of oncology drugs that enter phase 1 actually receive FDA approval. So patients with rare cancers, such as NETs, experience some unique challenges, including limited public awareness and inconsistent provider experience with the disease, which often leads to a delay in diagnosis. Due to that, patients often enter the clinical trial landscape with a healthy dose of skepticism and confusion about their treatment options. NETs often require multidisciplinary management, including endocrinology, oncology, surgery, nuclear medicine, which is not always available within a local healthcare system and may require regional specialty centers. And this fragmentation can further complicate trial enrollment or participation. The high diagnostic and monitoring requirements, such as frequent imaging, lab assessments, and follow-up appointments, impose substantial physical, emotional, and financial burdens on these patients. So this is where the advocacy groups really help. These organizations can provide education, community support, and help navigate clinical trials effectively. Rare cancers also present unique challenges to researchers, primarily in the fact that there's a limited patient pool. The net rarity limits eligible participants, resulting in prolonged recruitment and need for multi-center collaboration. The tumor heterogeneity that we see with these tumors, which vary widely in grade and biology, complicate eligibility criteria and require complex stratified trial designs. And the geographic barriers that are true for patients are also true for researchers, in that specialty net centers are limited geographically and create those travel and financial burdens to the patients. So how can we improve on the patient experience? First and foremost, reducing trial burden and improving logistics. We try to provide transportation support whenever possible. We negotiate with sponsors to pay for travel, to pay for lodging. We try to offer flexible scheduling and fewer in-person visits. Not always possible because these visits are dictated by the protocol, but you can negotiate with the sponsor to try to minimize some of the in-person visits and allow some of the assessments to be done locally. We also try to complete multiple procedures during in-person visits. So if we're screening a patient for a trial, we try to do all of the screening assessments in one day to limit how many times they need to visit the clinic. Expanding digital and decentralized options, use of mobile apps for scheduling reminders and information, implement telehealth visit and remote monitoring, again, when possible, and the use of electronic diaries to record patient-reported outcomes. We also have to be very sensitive to the fact that clinical trials have a checkered past with certain demographics. There have certainly been abuses with clinical trials, and we have to be sensitive to that and be aware that some people are entering these trials with a lot of fear and hesitation. We try to provide plain language study material, again, financial support whenever possible, and partner with community outreach groups for recruitment and education. Because we recognize that access to clinical trials is a very important mechanism to decrease healthcare disparities, which ultimately can lead to better health outcomes. So for the last part of my talk, I'll talk about the clinical trial portfolio that we have at LSU. Again, just to kind of bring awareness to the trials that are available right here in your backyard. In the phase 1, we have, oops. This is so sensitive. Okay, I won't touch it. In phase 1, we have the BRAVEST study. This is a dose escalation, dose expansion, first in human study, assessing the safety of CRN09682, which is a non-peptide conjugate of an SSTR2 binding non-protein to a cytotoxic agent. And we affectionately call it the cytotoxic bomb. This study is, God blessed. This study is currently open to enrollment. In phase 2, we have the AlphaMedix phase 2 study. This was a study testing the efficacy and safety of PB212 dotamtate, and this was a first-in-class targeted alpha therapy tested in the neuroendocrine patient population. And I'll talk a little bit more about that in this slide. The paltusotine phase 2 study, this is sponsored by also sponsored by Crinetics, looking at, so paltusotine is a first-in-class non-peptide selective SST2 agonist being tested in adults to treat carcinoid syndrome. This study has met primary and secondary endpoints and has progressed to a phase 3 study, which we also have open at LSU. In the phase 3 space, we have the Sorrento study. This is a study sponsored by Camurus. CAM 2029 was being compared to long-acting octreotide or lanreotide. CAM 2029 is a proprietary formulation of octreotide which allows it to be delivered in what's essentially an EpiPen style syringe and allows patients to self-administer the octreotide versus having to visit an infusion clinic, which is very burdensome for patients who've been getting shots for 20 years. The Action 1 study, sponsored by RayzeBio, is looking at RIZ101, which is another, it's another alpha emitter using actinium-225 versus standard of care. We have patients in this study, but it's no longer open to enrollment. So as I said, the paltusotine has moved on to a phase 3 study called CareFinder. This study includes a randomized, placebo-controlled, blinded period, but also includes a crossover period that allows any patients who may have received placebo in the blinded portion to cross over and receive the study drug. The NETA-3 trial by Novartis is looking at the safety and efficacy of lutetium dotatate in newly diagnosed neuroendocrine patients who have grade 1 and 2. So normally you would not use PRRT until patients have progressed on an SSA, on the somatostatin analog. In this study, we're using it as a frontline therapy. So any newly diagnosed patient that you may have, instead of starting them on lanreotide, please consider this trial. The Stellar 311 study by Exelixis is looking at the safety and efficacy of zanzalintinib. Zanzalintinib is the next generation tyrosine kinase inhibitor. It is basically meant to replace cabozantinib. It has the same targets as cabozantinib, but a shorter half-life and should have a better side effect profile. So again, the green studies are open to enrollment, so if anything sounds like something that might be a fit for a patient that crosses your path, let us know. On the horizon, we have the VMT AlphaNet phase 1/2 study by Perspective Pharmaceuticals. I'll talk a little bit more about that in another slide. In phase 2, we have NET Retreat, which is an NCI trial, which will retreat patients with 2 doses of Lutathera following completed 4 cycles of PRRT. And phase 3, the Oranomed AlphaMedix phase 3 study, which was meant to compare PB212 dotamtate directly versus Lutathera. This study is on hold currently, and I'll talk a little bit more about that in a second. So the AlphaMedix phase 2 study, the sponsor has released some of the information, has published the information on the results of that study. So PB212 dotamtate, again, this is an alpha emitter versus a beta emitter, which is lutetium. And just as a quick reminder, alpha particles have a much shorter path length, and so they should cause less collateral damage. And they also have a much higher linear energy transfer, which causes double-stranded breaks, DNA breaks, that are much harder for the cells to repair. So it should increase the therapeutic effectiveness of this therapy. So the AlphaMedix phase 2 trial looked at 2 cohorts of patients. They looked at PRRT naive patients, as well as patients who had previously been treated with PRRT, and reported both investigator assessments and blinded independent central review assessment. This study had a very impressive overall response rate of anywhere between 57 and 60%, just kind of depending on if it's central review or investigator. And a progression-free survival rate at 36 months of anywhere between 72% and 83%. And a 36-month overall survival rate of 88.2%. In the previously treated cohort, overall response rate was reported at anywhere from 19% to 34%, while progression-free survival at 18 months was reported at 82 to 88%, with an 18-month overall survival rate of 85%. The adverse events that were reported for this study included some side effects that were expected and mild, including alopecia, nausea, fatigue, as well as lymphopenia, which was severe in some cases. There were some grade 3 and 4. However, they were described as not clinically significant by the investigator. However, there were some long-term side effects that were more severe, including renal insufficiency, in some cases severe, grade 3 and 4, in about 17% of the naive cohort. 6 of these patients did develop chronic kidney disease and eventually developed kidney failure. Another unexpected adverse event was dysphagia. which was variable in severity but can require intervention, including Botox injections or surgery, and does affect approximately 50% of the patients. It's a very common side effect that we see with this therapy, including 2 cases of aspiration pneumonia. So given the impressive objective response, but the serious concerns about renal toxicity, several companies are trying to develop alpha particle-based radioligand therapies that will improve renal clearance. The goal is to reduce uptake and retention of radiolabeled peptides in the proximal renal tubule cells and decrease the risk of radiation-induced nephropathy. So this is the study I mentioned earlier, sponsored by Perspective Pharmaceuticals. They are looking at a compound called PB212-VMT alpha-NET. And this compound has a proprietary chelator, which has a neutral charge. So in contrast to DOTA, which is used in the previous radioligand therapies, which has a positive charge, this one is neutral and should reduce the electrostatic interactions of the renal tubule cells and reduce uptake. This study will include GEP nets, bronchial nets, PHEOs, paraganglioma, and meningioma, and will include dosimetry studies to carefully monitor renal absorbed dose. So RayzeBio also has a radiopharmaceutical agent that they've developed called RIZ SSA that they'll be testing in the RIZ 401 phase 1 study. This is a cyclic 6-amino acid SSTR targeting peptide conjugated to DOTA coupled to actinium-225. And again, the sponsor believes that this will result in less renal uptake and otherwise be able to access them. Patients who are underinsured, uninsured, have no access to any of these therapies. And so we continue to build our trial portfolio. We want to give as many options to patients as possible when they walk in that door, especially in that ever-increasing difficult landscape of insurance coverage. And we continue to partner with medical centers, sponsors, and advocacy groups to make these trials as feasible for patients as they possibly can be. And then before that music comes on, I just want to thank our incredible group. Dr. Maluccio is our medical director, Dr. Boudreau, Dr. Ram, as well as our clinical staff and nurses, Jenny, Terry, Marlene, Casey. Without them, our clinic would implode in exactly 45 minutes. And I also like to thank the LSU Cancer Center, who provide coordinator research support. And the coordinators, as you know, are the backbone of these clinical trials. So thank you to them, and of course our patients. We couldn't do this without them. And then thank you for listening and not running away with that music.
Thank you, everybody, for sticking around. My name is Catherine Chang. I'm an assistant professor of otolaryngology, head and neck surgery at LSU Shreveport. I'm a relatively new transplant to Louisiana. I started in September, and I'm really happy to be here. Today, I want to discuss the current landscape of HPV-positive head and neck cancer. This is now one of the most common HPV-related cancer. It surpassed cervical cancer. And now the incidence continues to grow. It's the #1 head and neck cancer that we see. It's surpassed drinking and smoking-related cancers. I have no conflicts of interest. And so I'd like to first talk about some history of how this disease has evolved over time. Before 1990, head and neck cancers were seen in smokers and drinkers. These were patients that were a pack-a-day smoker since they were teenagers, very heavy drinkers, and oropharyngeal cancers. And when I say oropharynx, oropharyngeal cancer, I mean cancers of the tonsil, the soft palate, the base of the tongue, and the back of the throat. Oropharyngeal cancers fell into the same category. It was primarily a disease of smoking and drinking. And surgery was the mainstay of treatment, and back in this time, this was done open, and so we would split the mandible, divide the floor of mouth, move the tongue over to get back to the oropharynx. We would sometimes go through the neck, what was called a lateral pharyngotomy approach, where we divide the pharyngeal constrictor muscles off the hyoid bone and get to the oropharynx that way. And as you can imagine, as you see from these pictures, these approaches were fairly morbid. They caused significant dysphagia, a lot of G-tube dependence, and tracheostomy dependence. Now, the paradigm started to shift in the 1990s with the popularization of conformal radiation. And it's important to note that radiation has become quite sophisticated over the last several decades. When we were first giving radiation to patients, they were literally 2 beams targeting the tumor, and they delivered a lot of radiation to the tumor, but also a lot of radiation to the surrounding tissue. Then came 3D conformal radiation, where we are able to angle these beams more specifically to target the tumor and then spare some of the surrounding tissue. And then moving on to the far right, intensity modulated radiation, or IMRT, which is now really the standard of care for head and neck cancer radiation. Many more beams, many more angles, and this allowed really contouring and conformation to the tumor to target the tumor specifically and spare some of the surrounding tissue. And so this kind of became the standard of care for oropharynx cancer starting in the 90s. Around this time, in the mid-1990s, there was growing recognition that a subset of oropharyngeal cancer patients did not have the classic head and neck cancer phenotype. We were seeing it in younger patients, healthier patients that often didn't have a strong smoking or drinking background. And these patients seemed to have a really positive response to the conventional therapies. We now know that these patients were likely HPV positive, and in fact, the prevalence of HPV has grew from just 10% of oropharyngeal cancers in the 90s to now over 50% of cancers in the 2000s, and that number is even higher today. Now, there was growing suspicion that HPV could be implicated, as it was in cervical cancer. There were many epidemiologic studies. There was one study actually done in Sweden, which found higher tonsil cancer rates in the husbands of wives who had cervical cancer. And so there was already this relationship being drawn that this could be sexually transmitted. It's a ubiquitous virus. So how does HPV actually cause carcinogenesis? HPV actually integrates into the host genome and leads to overexpression of two oncoproteins, E6 and E7. The E6 protein binds to P53, which is a critical tumor suppressor, and it prevents cells from undergoing apoptosis, which is a really important mechanism for cell regulation. The E7 protein binds to the retinoblastoma protein, another critical tumor suppressor, and this induces cells to persistently be in the S phase during the cell cycle. And so both of these pathways result in genomically unstable cells divide and divide in this unregulated fashion, leading to tumorigenesis. Now, the landmark paper, which really established HPV-associated cancers as having a better prognosis, came from a clinical trial, RTOG-0129, and this study was actually looking to see if accelerated fractionated radiotherapy was less toxic than the standard fractionated therapy we were giving to head and neck cancer patients. But they were able to look at oropharyngeal cancers by HPV subtype, and they found, highlighted in yellow, that these patients had significantly better survival compared to the HPV negative patients. Overall survival at 5 years was 84% if you were HPV positive, compared to only 57% if you were HPV negative. And so as I alluded to earlier, these patients are phenotypically different than your classic smoker, drinker, head and neck cancer patient. These patients are younger, typically in the 40s and 50s. They're healthier, and they don't really smoke or drink. Now, in Louisiana, a lot of HPV cancers are still in smokers, but it's important to realize that these risk factors are not driving their cancer. These are patients that are lawyers, they're engineers, they're accountants. I've even treated other ENT physicians with tonsil cancer. I put up this picture of a marathon runner because I've treated 2 patients now that asked me, after surgery, how long they would have to wait until they could start training for their Ironman. And so it's a very different patient population. And that's what makes treating this disease a slightly different problem. The good news is that their prognosis is better. They have excellent survival. These are younger, healthier patients, better baseline functional status, and they're living longer. But that's the problem. Now the toxicities of treatment are actually relevant in these patients. We're dealing with an increasing number of patients who are living longer and having to live with the very real consequences of treatment toxicity. And so what is that treatment toxicity? Radiation is very hard when you're getting it for head and neck cancer. Patients have significant dysphagia due to the fibrosis of the oropharynx, the pharyngeal constrictor muscles. They can get trismus if they're radiating the muscles of mastication. Xerostomia, as we talked about earlier, that really zaps all those salivary glands in the mouth. Taste disturbance, and then on the more serious side, you get osteoradionecrosis and even vertebral osteomyelitis, which I've seen. And so this is just a picture of what osteoradionecrosis of the mandible looks like. The radiation essentially causes hypoxia in the bone, and they get this demineralization that can actually progress to a pathologic fracture. So there was a need for treatment de-escalation. These patients were responding well to our conventional therapies, but the question became, how can we maintain the excellent survival that we were seeing, but somehow minimize the amount of radiation and the amount of treatment we were giving to improve quality of life in these patients that are now living longer? And so we did try that, reducing the radiation. As I said, definitive chemoradiation was sort of the standard of care. This NRG trial, HN005, was performed in non-smoking HPV oropharyngeal cancer patients, and it aimed to decrease the amount of radiation we were giving. And so they compared standard of care, patients getting cisplatin chemotherapy, 70 gray of radiation, that was the standard, and they're reducing it to 60 gray. They had two arms, one with cisplatin, one with nivolumab, which is an immunotherapy. They actually had to stop the trial early because they noticed that in the experimental arm, where they were getting decreased radiation, these patients were having significantly worse progression-free survival. And so the conclusion was that we cannot safely de-escalate the radiation if we were looking to give it definitively, and thus really reduce the enthusiasm for de-escalation efforts in the definitive CRT setting. So we began looking at surgery again. Now, minimally invasive surgery was already getting popularized with laparoscopic instruments and the robot in CT surgery, urology, gyn-onc. And so surgery was kind of moving in this minimally invasive direction. And we too began exploring minimally invasive transoral surgery for oropharyngeal cancer patients. So transoral laser microsurgery, or TLM, was one of the first kind of minimally invasive techniques for oropharynx cancer. You essentially suspended the patient with this metal retractor that opened the mouth, and we use this for tonsillectomies in kids. We brought in a microscope, a CO2 laser, and we were able to cut this tumor out completely transorally. We didn't have to split the mandible, we didn't have to go through the neck, and so it was less morbid. And the rationale was that if we could resect these tumors, we could, one, maybe get rid of radiation altogether after surgery, or two, reduce the dose of radiation, minimize some of that toxicity. And the early data on this actually showed pretty promising results. Overall survival, disease-specific survival with this TLM showed 80% at 5 years. And then if you looked at the functional outcomes, they were also pretty good. You had the majority of patients reporting 0 to mild dysphagia at 5 years, and very low rates of G-tube usage long-term. Now, around the same time, the Da Vinci robot was growing popular, again, in CT surgery, gyn-onc, and urology, so, why not the oropharynx? The robot was designed to improve visualization in hard-to-reach areas and operate in hard-to-reach areas like the oropharynx. And so this was actually, Bert O'Malley and Greg Weinstein were sort of accredited as the founders of transoral robotic surgery, or TORS, in 2005 at UPenn. The robot has undergone multiple iterations and is now FDA approved for T1, T2 oropharynx cancers. So the option of minimally invasive transoral surgery, either with the laser or the robot, really re-energized the concept of de-escalation. The question being, if we could get patients to surgery, can we, one, eliminate chemotherapy and radiation altogether, or two, reduce the dose of radiation? So this was the first trial actually comparing chemotherapy, standard of care chemotherapy and radiation to TORS, which is like crazy to think about randomizing patients to chemotherapy versus surgery. But they compared patients that got 70 gray of radiation and cisplatin to patients who got transoral robotic surgery, and then they got 60 gray after surgery, and that's kind of the standard adjuvant dose. As you can see, survival and progression-free survival were fairly equivalent between the two arms, so it is at least just as good in terms of disease control. Now, the study's primary endpoint was looking at swallowing outcomes, and they measured this with the MDADI, which is a quality of life measure of swallowing dysfunction. They found that 1 year after treatment, the MDADI scores were actually slightly higher in the chemotherapy radiation group, but that over 5 years, the two curves kind of converge, and there was really no difference in swallowing outcomes. And so this study seems to suggest that TORS with radiation afterwards was similar in terms of oncologic outcomes to CRT, and probably similar to swallow function, but there wasn't like a big benefit with it. Now, the study is criticized for a couple of reasons. One, at the time that the study was done, we were taking much bigger margins of the cancer with surgery than we're doing today, so that obviously adds to the morbidity, and we're also giving them more radiation than we are today. But in general, the swallowing outcomes with transoral surgery were clearly superior to that of the open approaches. And so we started shifting the paradigm back to surgery for select patients, especially the early stage patients. And so then the question became, that people wanted to investigate was, well, if we do this transoral surgery approach, can we bring down the radiation dose even further? So 3311, this was an ECOG study. It basically took early stage T1, T2 tumor patients who all got transoral robotic surgery, and then after surgery, the patients were stratified into 3 groups: low, intermediate, and high risk. So the low risk patients, these were patients that had widely clear margins, 1 positive node. They didn't get any radiation or chemotherapy afterwards. The intermediate risk patients, these are patients with 2 to 4 positive nodes, maybe a little bit of extranodal extension on the nodes. They got randomized to receive either 50 gray or 60 gray. And so that 10 gray difference, they were trying to investigate whether they could still preserve those oncologic outcomes. And then the high-risk patients with positive margins, tons of lymph nodes, these patients were not eligible for de-escalation, and they got chemotherapy in addition. And so what the data showed was that progression-free survival at 3 years was equivalent in all groups. So importantly, this de-escalated group of patients that got less radiation after surgery had the same progression-free survival as the higher dose radiation group. And swallowing outcomes were excellent across all groups. And so in conclusion, yes, we can safely de-escalate patients down to 50 gray if they get surgery. So we were able to decrease from 60 to 50. How low can we go? The Mayo Group has sort of led a lot of the de-escalation efforts. This is the DART HPV trial. They took really that same group of patients, gave them transoral surgery, and then split them into the same risk groups, intermediate and high risk. Now, they reduced the radiation dose to 30 gray in the intermediate risk group. So not 50, but 30. And then even in high-risk patients, these are patients who have extranodal extension. They only gave them 36 gray of radiation. They also gave them 2 doses of docetaxel, which is a chemotherapy, and they compared that to the standard of care, which was 60 gray at the time. And so what they saw was a lot less toxicity in the de-escalated arm, which makes sense. You're giving them like almost half the radiation. So toxicity was 3% in the de-escalated arm, 11% in the standard of care arm. G-tube dependence rates were also significantly lower, 2% versus 8%. Now, when you looked at the patients based off of E&E, or extranodal extension, this is when cancer has spread to the lymph nodes, it's gone beyond the lymph node capsule. When you look at the E&E negative patients, de-escalation seemed to work. They had excellent progression-free survival, indistinguishable from the standard of care. Now, in E&E positive patients, you see that blue curve. These patients had significantly worse progression-free survival and local regional control. And so, in conclusion, we could probably de-escalate these patients all the way down to 30 gray if they didn't have E&E. But this was probably too aggressive of a de-escalation for these E&E positive patients. So besides reducing radiation, what else can we do in the de-escalation realm? How about we give no radiation at all? And so the Nectar's trial actually looked at this. They gave patients with HPV positive oropharyngeal cancer neoadjuvant chemotherapy, 2 agents, cisplatin and docetaxel. Then the patients got surgery. They got TORS and a neck dissection. And then none of these patients got radiation afterwards. They demonstrated pretty excellent overall survival, low distant metastasis at 5 years, and good local regional control, very similar to the standard of care. What else can we do? Can we avoid radiating the oropharynx altogether? So in all these de-escalated patients, they were getting radiation to the neck, they were also getting radiation to the oropharynx. And that's where all the morbidity is coming from, radiation to the oropharynx. And so the question was, well, if you get widely clear margins of the primary tumor, can you avoid radiating the oropharynx altogether? At Penn, they conducted the AVOID trial, which prospectively looked at patients that got TOR surgery, and if they had clear margins, 2 millimeters, they were only given radiation to the neck. These patients had excellent progression-free survival at 2 years and almost no local failures. Many institutions like Emory and Penn are routinely not giving radiation to the oropharynx if they're able to get clear margins with surgery. Emory actually published this data. They had 59 patients that received no radiation to the oropharynx after surgery, and they had 0 local regional failures. What else can we do? Can we omit chemotherapy altogether? We've talked a lot about toxicity from radiation, but chemotherapy can be pretty toxic for patients as well. They get sick, they vomit, they don't eat, they're fatigued, their white counts can plummet, and we conventionally always give it for extranodal extension. The PATHOS trial, which is being done in Europe, is looking to see if we can omit chemotherapy in TORS patients who have positive E&E. The results of that study are still pending. So more recently, we have shifted towards TORS with de-escalation of radiation and chemotherapy in select patients that are lower intermediate risk. What else is on the horizon for HPV? And so immune checkpoint inhibition, you can't really have a head and neck cancer talk without talking about immunotherapy. But the immune system plays a critical role in head and neck cancer, and disruption of immune surveillance results in tumorigenesis in a lot of head and neck cancers. And this is really due to exhaustion of T cells, inhibiting their cytotoxic activity. Anti-PD-L1 inhibitors take advantage of this interaction that tumor cells have with T cells, where when the PD-L1 receptor binds with the PD-1 on T cells, they actually impair T cells' ability to recognize cancer cells and kill them. And so a lot of anti-PD-L1 inhibitors, anti-PD-1 inhibitors block this activity and thus activate T cells to target cancer. Now for HPV, immune checkpoint inhibitors are primarily used in the recurrent and metastatic setting. They're not really being used at this point as primary or neoadjuvant treatment, but that's certainly where a lot of the trials are headed. So the OPTIMA trial, this was a phase 2 non-randomized study that was done in University of Chicago, looking at stage 3 and 4 head and neck oropharyngeal cancer patients. These patients got neoadjuvant nivolumab, which is an anti-PD-1 inhibitor, carboplatin, paclitaxel, which are chemotherapy agents, and after they were treated with this neoadjuvant package, they were given risk-adapted treatment. They found that 70% of patients had at least a 50% tumor shrinkage with the regimen, and that resulted in 86% of patients getting de-escalated local regional therapy, and they were able to maintain pretty excellent progression-free survival. Now, it's hard to know whether this was all due to the immunotherapy because they also gave chemotherapy, but it appears that immunotherapy probably has a role in the neoadjuvant setting in helping us further de-escalate treatment for these oropharyngeal cancer patients. It's also been investigated in the adjuvant setting, in the maintenance setting. EA3161 is a clinical trial that basically looked at giving intermediate risk patients who were getting definitive chemotherapy and radiation, then giving them nivolumab after CRT for 1 year. This trial is currently close to accrual, and they're doing their analysis, and that's pending, so there's more to come there. There's also been a lot of focus on the HPV vaccine. It's now being recommended prophylactically for males and females during the reproductive years to prevent a lot of these HPV cancers. But there's also been a lot of interest in investigating the HPV vaccine in treating HPV cancers in combination with immunotherapy. These vaccines contain inactivated oncoproteins like E6 and E7. And so when you get the subcutaneous injection, these proteins are taken up by antigen-presenting cells, and they induce memory in the T cells so that the T cells can go specifically target HPV tumors. They combine this with immunotherapy, which again activates T cells to target tumors, and the thought is that these two things can synergize one another and make immunotherapy more effective. There was a recent JAM Oncology publication in 2019 that looked at the combination of an HPV vaccine with nivolumab and immunotherapy. And they did see, and this was an incurable head and neck cancer, 92% of these patients were oropharyngeal cancer patients. They observed an overall response rate of 33% in 24 patients, and 2 of these patients actually achieved a complete response. And so still a lot of ongoing research in this realm. Now I want to shift gears a little bit and talk about circulating tumor DNA. This is an incredible biomarker for this disease. They can actually measure the amount of HPV in the bloodstream. 80 to 90% of patients will actually have detectable HPV DNA in the bloodstream if they have oropharyngeal cancer. Why this is important, it helps us monitor these patients after they get treatment because that level should theoretically fall to 0. Now, the majority of head and neck HPV patients, when they fail, they're going to fail in the lungs. They actually don't fail in the neck or back at the primary site. And this makes it very difficult to monitor because I can look in the back of the throat, I can scope them, I can feel the neck, but it's really hard for me to monitor for distant metastasis and catch it early. And so ctDNA has actually allowed me to actually catch these recurrences faster. If they have a positive ctDNA, it really lowers my threshold to order a scan. Now, in addition to being a great tool for surveillance and monitoring for treatment response, there's been a lot of interest at looking at HPV circulating DNA as a risk stratification tool. Can we de-escalate patients if they have a negative ctDNA after surgery? So Emory actually conducted a phase 2 trial where they did just that. They took these intermediate risk oropharyngeal cancer patients who got surgery with TORS, and they had to have a detectable HPV DNA, obviously, at the time of diagnosis. 2 weeks after surgery, they then drew their ctDNA. Those that had undetectable levels were considered low risk, and they got de-escalated to 36 gray of radiation. If you had a detectable ctDNA at that time, you got the standard of care, which is 50 gray. In their interim analysis of 30 patients, 90% of patients actually cleared their ctDNA after surgery. The local regional control was 96% at 12 months. Progression-free survival at 12 months was 89%. They had 2 deaths that were unrelated to the cancer treatment. So it appears that, yes, we can further de-escalate patients if they have a negative ctDNA after surgery. The long-term analysis of this trial is not available yet, and they're currently in the process of making this particular study a national cooperative trial. So what's next for HPV oropharyngeal cancer from a clinical trial standpoint? Now that we're better at TORS, we're taking smaller margins, we're doing it more minimally invasive, there needs to be a new trial comparing CRT to TORS and specifically looking at dysphagia outcomes of both modalities. Do patients with extranodal extension need chemotherapy? We talked about how de-escalating their radiation was definitely a no-no, it was not safe, but do we need the chemotherapy? Pathos 2, which is that ongoing trial in Europe, will hopefully illuminate us on that question. Is there a role for immunotherapy beyond the recurrent metastatic setting? Can we use and leverage immunotherapy for the treatment of this cancer in the neoadjuvant and adjuvant setting, hoping that we could further de-escalate patients? What is the efficacy of combination immunotherapy in these HPV vaccines? And then can we de-escalate patients based on their HPV DNA? And so in summary, HPV oropharyngeal cancer patients have an improved prognosis and better survival than our average head and neck cancer patient. Treatment should be focused on minimizing treatment toxicity while preserving oncologic outcomes. TORS surgery allows for safety escalation of adjuvant treatment in early stage disease. And the role of immune checkpoint inhibitors in vaccines, it remains unclear, but certainly further research is needed. That's all I have. Thank you guys so much.
Hello. It's on. Hey, everybody. We're going to start the second line probably in about 5 or so minutes. If you want to make your way out in the atrium area toward the elevator, we'd love to have everybody be there. C is going to be handled at the end, after the conference. You're going to email.